I want to welcome everybody to the city of Fitchburg today. I apologize for my voice. I was at Bruce Springsteen last night. But it's my privilege to introduce Mayor Stephen DiNatale and Representative Mike Kushmarek for some welcoming remarks.
Thank you, Senator. Good morning, everyone. Welcome to Fitchburg. This is a really momentous occasion for us. We couldn't be prouder to be hosting the Ways and Means Committee, the Joint Committee here today. You guys really handle some important issues. I spent nearly 10 years in the legislature as well, so I know something of what you go through. But again, we're very, very proud and happy that we're able to host the Joint Committee's meeting here today. And again, thank you for the great work that you do for the Commonwealth and for the people of the city of Fitchburg included in that as well. Thank you and welcome again to Fitchburg.
Thank you, Mayor.
Everyone, thank you and welcome to the 3rd Worcester District. I'm appreciative of today's chairs, Senator John Cronin and Rep. Kathy Lenatra. Thank you both for allowing us this opportunity to not only address you, but address my former colleagues. Each of you, thank you for making the trip to Fitchburg. I truly believe that Fitchburg is a microcosm of the entire Commonwealth. Within half a mile of where you are right now, you could be on a farm, a college campus, a dense urban environment, in a manufacturing plant, a brewery. You name it, Fitchburg has it, and with it represents all of the challenges of the Commonwealth, but also all of the opportunities of the Commonwealth. And so I'm thrilled that you are here today and thankful for the work and the crucial work that you're doing today and in the weeks ahead as we move towards a FY24 budget for the state. So thank you. Again, welcome to Fitchburg and the 3rd Worcester District, and look forward to having more conversations with each one of you.
Thank you very much.
Thank you, Representative. Thank you, Mayor. Welcome, everybody, to the 2nd regional hearing of the Joint Committee on Ways and Means. Again, we're grateful to the city of Fitchburg. Everybody on the Joint Committee, our staffs, the clerks, court officers, and everyone whose worked really hard to allow us to come together today to confront these issues. I'm really pleased to be chairing this committee with my colleague, Representative Lenatra, today, and grateful to Chairs Michaelwitz and Rodrigues for the opportunity to have this discussion here in a gateway city in Fitchburg, in north central Massachusetts. The agencies here today are part of a critical safety net for the Commonwealth. They are our community responders for the Commonwealth's most pressing concerns. So thank you to everybody who is testifying today. I'm pleased to be joined by my Senate colleague, Senator Liz Miranda from Boston. And I will now turn it over to Representative Lenatra to welcome the members of the House.
Thank you, Senator Cronin. Good morning, everyone. Welcome to the 2nd hearing of the Joint Ways and Means Committee. I'm happy to join all of you today, and I'm very happy to be co-hosting with Senator Cronin. I would want to thank everybody, the town of Fitchburg especially, for graciously hosting today. I'd like to offer my gratitude to the clerks, the Legislative Information Services, and the court officers that make this possible to have the meetings that we are able to have today remotely. I would like to extend my thanks for all those testifying today, whether you're joining us by Teams or you're here in person. And I bring greetings from the House. And I would like to introduce the long list of esteemed colleagues in the House serving on Ways and Means. Some are here today with us, and some we have on Teams. But first, I would like to thank the work and leadership of our Chair, Aaron Michaelwitz, Vice Chair Ann Margaret Ferrante, Assistant Vice Chair Patricia Haddad, Ranking Minority Member Todd Smola, Russell Holmes, Natalie Higgins, I should say Rep Samantha Montano, Rep Stephen Altrino, Rep Alan Sylvia, Rep Vanna Howard, Rep Carol Doherty, Rep Patricia Duffy, Rep Sally Kearns, Rep Natalie Blay, Rep David Beal, Rep Andy Vargas, Rep Dylan Fernandez, Rep Meg Kilcoyne, Rep Orlando Ramos, Rep Patrick Kearney, Rep Kate Lifford-Garavedian, Rep China Tyler, Rep Bud Williams, Rep Brian Murray, Rep Rich Haggerty, Rep James Hawkins, Rep Christine Barber, Rep Angelo D'Amelio, Rep Matt Muratori, Rep Donald Berthium Jr., Rep Joseph McKenna, Rep Kelly Pease, Rep Allison Sullivan Omedia, and last but not least, Rep Stephen Exaros. We do have a long list of House members on this. Thank you for all of your hard work from this committee, and I look forward to hearing from all of you. Thank you.
Thank you, Representative. I also want to extend a welcome and recognize my colleague who's joining us on Teams, Senator Comerford. Senator, thank you for being with us today. I'd now like to invite Secretary John Santiago, the Executive Office of Veteran Services and Soldiers' Homes, to testify.
I'll be joined by Superintendent Mike Lazo, and Executive Director Robert Engel. Good morning, Chair Cronin, Chair Legislature, and distinguished members of the Joint Committee on Ways and Means. My name is John Santiago, and I am honored to serve as the first Secretary of the newly established Massachusetts Executive Office of Veteran Services, which was made possible with your leadership in reforming a broken system and passing Chapter 144 of the Acts of 2022. As a former legislator, I have tremendous respect for your leadership and extend my deep, heartfelt thanks for your continued support for veterans all across the Commonwealth. Thank you to the chairs and members for the opportunity to address you today and answer your questions about Governor Haley's FY 2024 House 1 budget proposal for the Executive Office of Veteran Services and the 2 veteran homes. I am joined here today by Superintendent Michael Lazo from Holyoke and Robert Engel, the Executive Director of Veteran Services, of Homes and Housing, who currently serves as the Acting Superintendent with the Veterans Homes in Chelsea. You will hear from them later. But first, I want to start by recognizing and thanking Cheryl Poppy for her long-standing service to our veterans as the former Secretary of the Department of Veteran Services. She has led the Commonwealth's Veteran Services work with a steady hand through some incredibly turbulent times. We are grateful for her service. As you are aware, the passing of Chapter 144 created a multitude of statutory and governance changes greatly impacting the Executive Office's role in providing services for our veterans. And those changes include elevating the Department of Veteran Services, which was under the Executive Office of Health and Human Services, to its own cabinet-level secretariat. The state-operated Veterans Homes in Chelsea and Holyoke now report to the Secretary of EOVS, including both superintendents. The homes must apply for and maintain certain DPH licensure and CMS certification and can be inspected twice annually by DPH. The establishment of an independent Office of the Veterans Advocate, who is to be jointly appointed by the Governor, the Attorney General, and the State Auditor. This office is not within or subject to the control of any other agency. Additionally, thanks to your support and the work of our dedicated staff, I am able to share that Massachusetts continues to be recognized as a national leader in providing veteran services and benefits, including monetary and non-monetary benefits, affordable housing opportunities, resources for women veterans, peer-to-peer outreach to help prevent suicide, and support in the operation of 2 veteran cemeteries in Agawam and Wichita. Not including the approximately $79 million allocated to operate both veteran homes, the Governor's House 1 budget allocates $106.5 million for FY 2024 to support ongoing programming from the Executive Office of Veteran Services. Key initiatives include the following: $68.2 million to support more than 7,000 individuals receiving Chapter 115 safety net benefits. Chapter 115 provides economic assistance to qualified veterans and their dependents to purchase necessities like food, shelter, clothing, fuel, and medical care. $32 million for the annuity program, which provides financial support by way of 2 $1,000 checks annually for nearly 17,000 individuals. Veterans must be 100% service-connected to qualify for this annuity. Gold Star parents or surviving spouses of veterans whose death was related to their military service are also eligible. This budget includes $9.5 million to fund veteran homelessness prevention efforts by way of contracting with direct service providers. Funding for emergency shelter providers such as the New England Center for Homelessness, Veterans, and Soldier On offer approximately 150 temporary beds each day. This past year, we announced nearly $4 million in new funding as part of the Department of Veteran Services outreach appropriation for increased services. This additional funding was able to reach our most underserved veterans and has provided for food and clothing, employment services, transportation to and from medical appointments, security deposits for veteran-specific housing, low or no-cost housing upgrades, and counseling for female veterans struggling with PTSD. The budget also includes $4.2 million to bolster information technology for the 2 veteran homes and improve service delivery through a new IT office responsible for IT strategy and delivery. $2.2 million to cover the additional cost of the elevation to a secretariat. This will allow for the creation of a new human resources and labor relations office, expand our existing legal, finance, legislative, and communications functions that, once staffed, will help increase EOVS capacity to deliver effective, responsive, and timely services. Funding will also support our 2 veteran homes to maintain critical staffing and infrastructure improvements, including preparing for the opening of a new veterans home facilities. You'll hear more about that from our 2 superintendents. The governor's budget also includes $1.5 million to support vital peer-to-peer outreach services through the statewide Advocacy for Veterans Empowerment Program, otherwise known as SAVE. SAVE is a peer support program focusing on suicide prevention, jail diversion, and substance use mental health treatment. The Women's Veteran Outreach Program budget recommendation is for $629,000. Women veterans comprise the fastest growing segment of our veteran community, now representing almost 25,000 individuals in the Commonwealth. This past year, the WVN conducted its first statewide survey of women veterans in decades to better understand the services that women veterans in the Commonwealth currently use. In conclusion, Governor Healey's House 1 budget proposal is committed to meeting the moment and supporting our veteran community. My priority as the first Secretary of Veteran Services is to build out a robust secretariat in order to further scale up our veteran support programs and provide that needed financial assistance. Given our shared vision and desire to see the veteran community excel, I urge your support for the governor's budget requests and for our office. I'm happy to answer any questions you may have before inviting the superintendents to speak. Thank you.
Thank you, Mr. Secretary. I'd like to open it up to the committee for any questions.
I just have a question. Hello, Mr. Secretary. So good to see you. So being the new secretariat, what are the goals for establishing the executive office in FY24?
Really, the goals come down to one thing. It's how do we rebuild trust in the veteran community? This is effectively a startup and a turnaround in some respects. The governor has invested a significant amount of financial human resources to do just that. Now, I'm here with our superintendent from Holyoke and our superintendent in Chelsea, who are committed to changing the culture, rebranding the institution to best serve our veterans. As I've stated before, she's invested millions to do just that. We have a whole host of issues that need to be addressed, but I think in their testimony, you'll hear more about what's going on in the respective homes, how they've changed operations, how they've changed infection control procedures to make the situation significantly better for the veterans, their staff, and their families.
And do you expect the funding for in H1 to exceed those goals? Do you think that's going to be enough for those goals?
I think so.
Okay.
I think we're pretty excited about the funding that they're receiving. Additionally, the governor has invested about 11% increase in our operations. I mean, it's quite a task. This was a department in HHS. I think it was one of 16 there. Now, the transition from a department to a secretary comes with a certain level of expectations and professionalism. The funding is going to allow us to do just that. We're in the midst of hiring a whole host of people who are going to lead those efforts, from the director of HR, who just started yesterday, a legislative director, chief information officer, who are all starting on April 3rd, a deputy comms director, you name it. We're excited about it. It's a big task at hand, but the team is committed to doing the job.
Great, thank you.
Hi. Great to call you secretary to my colleague.
Thank you, Senator.
And fellow Bostonian. I'm the chair of the Racial Equity, Civil Rights, and Inclusion Committee, and you obviously are a Latino man, an active duty, and also a doctor. And I had the honor of serving on the Veterans Committee in the House for 4 years. I have a specific question around how we're serving I'm glad to hear about the women, but Black and brown veterans, we have approximately 380,000 veterans in the Commonwealth. Massachusetts is a great state, not only for the veterans that are from our state, but many veterans flock to our state for job opportunities each year. Do you have any specific goals related to that population? Because one of the things that really struck me during COVID-19 was not only the substance abuse disorder, but the homelessness and the mental health challenges of our veteran populations, which skyrocketed.
Well, thank you, Senator Miranda, for the question. I share your concern, I share your empathy, and your desire to treat veterans, and particularly veterans of color, as a person of color myself, and someone who's served, who's deployed twice. I share those concerns deeply, and I'm committed to making sure that the office, as it's represented, also reflects that in our hiring and what we do. In fact, as we create this organizational chart, which we hope to fill as soon as possible, there are elements of it which will address diversity, equity, inclusion. And so hiring people that represent the community, making sure that they're playing an important role and throughout the entire secretariat is something I'm committed to doing. But first and foremost, making sure that we're out there engaging with these communities. I'm committed to doing it in a culturally sensitive and linguistically appropriate way. And as a Bostonian, as someone who serves these communities, it's something I care very much about, and that's something I've talked to the governor about, and she's committed to it as well.
Thank you.
Representative Peace.
Yes, hi, good morning, and thank you so much. Now, I'm not sure if this question is maybe more for the superintendent, but I know that the Holyoke Soldiers Home used to have an outpatient clinic there that got shut down, and I'm not sure if it just got shut down because of COVID. I mean, we're fortunate also to have a VA out there, but a lot of my constituents said really liked going to that outpatient. I was wondering if there's any plans to put that back in place.
Thank you for that question. At this point, there are no plans to reopen. In fact, that outpatient services has been closed permanently. It will be replaced by the adult day health in the new building.
Thank you.
Thank you. Good morning to my former colleague. As the senator said, so accomplished. I always feel like a bit of a slacker when I'm talking to John Santiago. Just a quick question about the North Shore Veterans Counseling Center. It's in Beverly, not my district, but my daughter happens to live 2 doors away. Where in your budget do you think that and similar services for veterans? I don't ever seem to see women going in and out. So is an expansion of counseling services for women and for all veterans, is that part of the $106.5 million?
Well, let me just state emphatically that, similar to Senator Miranda's question, we remain committed to supporting our women veterans. There's about 25,000 across the Commonwealth. It's the fastest growing community with respect to the veteran community. And as you know, there was an audit done by the previous auditor that said, look, things aren't going as well as they could be going, right? There's a lack of strategy. There's a lack of investment. And what our office did before I was there last year, I think September 19, 2022, they underwent a survey. They hired a consultant to bring in and to come in and say, listen, what do we need to do to best serve our women veterans? And in that study, which is public, they provided a whole host of different strategies and plans to do just that. Now, I'm in my 3rd week in the office. I've read the study, but let me just tell you that we're committed to implementing that vision. As I said, it's the fastest growing community in terms of the veterans, and we want to make sure that they have the support that they need and that they deserve. I mean, they serve their country, and we're committed to supporting them. You know, what's unique about this particular position, listen, I'm a physician, as was mentioned. I've served, been in jobs that are pretty inspiring. But already in week 2 or week 3, wherever we're in, everywhere I go, it's a pretty inspiring job, hearing the stories. And I don't care what your ethnicity may be, what your gender may be, everyone is always rooting for a veteran. And we take that with us in the work that we do day in, day out. It's very palpable on the streets, in the veteran homes. And we're committed to making sure that veterans across the Commonwealth know that we have their back.
Thank you.
Thank you, Mr. Secretary. I have a question. I'm wondering if you could speak to how the change and expansion of DVS to a secretariat-level department is impacting the operations of our soldiers' homes. And to dovetail off that a little bit, I think one of the things that we hear from our healthcare system all across the state is the incredible workforce shortages. And I'm wondering if you could speak to some of those challenges at our soldiers' homes and ways that we can help.
Yeah, so let me take the first part. I don't know if it's okay with you, Mr. Chair.
Please.
They have some testimony that they might be able to enlighten you all with some of the issues and challenges that they're currently facing. But let me get that first part of the question. So as I said, the governor has invested significant financial human resources into the building secretariat, but much of that is internally. Prior to this, we had been dependent on EHS for a whole host of different services, whether that was HR, whether that was general counsel, whether that was our communications department. So now we are building out this whole program and this whole operation. And it's challenging. Ever since I took office, I feel like every day I'm interviewing 3 or 4 people for a variety of positions. And we've had some luck putting in at least 10, 11 folks already in senior positions. It's going to take a lot of work, a lot of reviewing of applications and interviewing to get this done. But I view that as somewhat separate from what's going on at the homes. Now, they provide capacity at the secretariat level, and they will provide support for what's happening there. Each home has their own HR team, their own comms team, but we want to support them to the best of our abilities to make sure that they're adequately resourced and able to do the job. But I think in their testimony, they will provide you some insight as to what's going on right now at Holyoke and at Chelsea.
Great. And if you want to provide that testimony, please.
Sure. All right, thank you very much. Good morning, Chair Cronin, Chair Lenatra, and members of the Joint Commission on Ways and Means. My name is Michael Laswin. I'm the superintendent at the Veterans Home in Holyoke. Thank you for the opportunity to testify on behalf of the Veterans Home in Holyoke. Governor Healy's fiscal year 2024 budget proposes $30 million to support the mission and priorities of the Veterans Home in Holyoke. The budget funds robust staffing levels to support quality care and continues to make substantial progress in clinical and infection control protocols. As we transition to the new reporting structure on the Executive Office of Veteran Services, 2023 will be a turning point for the Veterans Home in Holyoke. As of March 1st, under EOVS, our name has changed to the Veterans Home in Holyoke. Still, our mission remains the same, providing care with honor, dignity, and respect to Massachusetts veterans. Planning for the future of the new Veterans Home in Holyoke will also become a reality this year, as a domiciliary building was permanently closed in preparation for the groundbreaking of the new facility and the Adult Day Health Program. Currently, staffing levels, we are currently at 315. The staff takes great pride in providing care to the 108 veterans currently residing at the Veterans Home in Holyoke. Plans are underway to expand our workforce in preparation for the new Veterans Home in Holyoke, which will house 234 long-term care veterans and care for up to 50 in the Adult Day Health Program. All the progress we have made in the planning for the future are only possible with our dedicated team. Throughout the public health crisis and the period following, the staff has shown resiliency, flexibility, and dedication in caring for our veteran residents. They remain steadfast and vigilant in compliance with infection prevention and control measures and are following guidelines for the well-being of our veterans and each other. The Veteran Home continues to engage in the recruitment of qualified clinical and non-clinical staff. The Veteran Home has focused on recruiting and hiring direct care staff such as CNAs, LPNs, and RNs. We have filled critical positions such as the Recreation Director and the Budget Director. The home also utilizes contracted agency staff to support strong patient care staffing patterns. As a result of increased staffing, our hours per patient day consistently remains above the CMS 5-star rating standard of 4.408 hours for a skilled nursing facility. Our January 2023 average hours per patient day was 7.59. We look to build our team and remain focused on continuously recruiting qualified clinical staff. The home will work with a consultant to conduct a staffing assessment to begin laying the groundwork for staffing needs for the new Veterans Home in Holyoke. The modern design of this new facility will require additional clinical and non-clinical staff to maintain the 234-bed facility at appropriate levels. The Veteran Home in Holyoke provides quality care and maintains high standard as evidenced by successful surveys this past year. In January 2023, the U.S. Department of Veteran Affairs surveyed the home's long-term care facility. The final report showed that out of 472 standards, the home met 466, or 98.7%. Only one of the findings was of a clinical nature. The corrective action plan has been written, reviewed by EOVS, and submitted to the VA on March 15th. The VA will review and will return an accreditation decision over the coming weeks. I am very confident the home will receive accreditation. The Joint Commission, which is an independent, not-for-profit accreditation organization, surveys the home every 3 years, and they visited the home in June of 2022. On September 9th, 2022, the Veteran Home in Holyoke received accreditation from the Joint Commission. The home conducts customer satisfaction surveys with a national survey firm. In calendar year 2022, the Veteran Home Monthly Satisfaction Survey, conducted by Pinnacle Insights, resulted in an overall satisfaction rate of 96.3, which is a 9.3% increase over 2021. Pinnacle Quality Insights conducts surveys with loved ones and residents to provide feedback and measuring tools to help us improve overall satisfaction. The surveys are essential because they provide us with actionable data that can help improve customer experience. The Soldiers Home in Holyoke scored in the top 15% of homes across the nation over a 12-month period. As a result, the home earned Pinnacle Customer Experience Awards in the following area: overall satisfaction, nursing care, food quality, cleanliness and individual needs, communications from the facility, response to problems, dignity and respect, recommend to others, activities, and overall customer experience. Recreational activities with volunteer support continue at the home. Recreation Department maintains a complete activities calendar, emphasizing activities that meet the 5 domains of therapeutic recreation. The domains are cognitive, physical, emotional, social, and spiritual. The Veterans Home in Holyoke is planning for the future in partnership with the Executive Office of Health and Human Services, the Executive Office of Veteran Services. The Division of Capital Asset Management and Maintenance continues to make significant investments to address the short and long-term needs of the home. I again want to thank the Legislature for securing the capital authorization to construct a new long-term care building for the Veterans Home in Holyoke. The application to the U.S. Department of Veteran Affairs State Home Construction Grant Program is coming to fruition. The home has received a conditional award of approximately $160 million to begin construction of the new Veterans Home in Holyoke. Thank you to DCAM for their hard work in procuring the necessary documentation to complete the grant process to secure this conditional grant. We look forward to a groundbreaking ceremony with the Haley Driscoll administration. Ongoing construction efforts continue in the current facility to improve our isolation unit by making it a fully enclosed negative pressure space. This project will close in the coming weeks. Additional projects regarding emergency power generation and the facade improvements are in the planning phases. The home is working towards becoming certified by the Centers of Medicare and Medicaid Services and licensed by the Department of Public Health as a nursing home. The home has engaged an external consultant, and our staff has been working to incorporate changes and recommendations by this expert. The home will be submitting applications as soon as possible. Another important initiative that we have underway is the implementation of electronic medical records. In collaborations with the Veterans Home in Chelsea, we have contracted with an EMR vendor and will be moving forward with implementation following a final decision and contracting for the implementation vendor. The Holyoke team is looking forward to progressing in this important initiative. The home in Holyoke continues to engage with community partners. This past year, I was invited to the Chicopee Senior Center to provide information on the new Veterans Home in Holyoke. We had a great discussion, and I appreciate the opportunity to meet with this community. I was also invited to represent the Veterans Home at Holyoke's Wisteria Hearst Museum's Translating Uniforms and Understanding Service exhibit. Our veterans are also returning to the community for the second year in a row. The veterans and staff of the home in Holyoke have joined the city of Holyoke in the St. Patrick's Day Parade. It is a great event, truly enjoyed by our veterans, and it has been a pleasure of reintroducing the home to the local community. Local veterans organizations and VSOs are integral to the missions of the Veterans Home in Holyoke. Their volunteer power and support are part of the daily life of our veteran residents, and we sincerely appreciate their partnership with the home. We hold our quarterly veteran community engagement meetings to keep them abreast of our work with our veterans and to gather their feedback. The most recent meeting was held on February 13th, providing updates to local veterans organizations and veteran service officers. This meeting keeps an open line of communication to better serve veterans in the community and at the home. Along those same lines, the home continues its community newsletter called The Front Lines to keep the community informed and updated. In conclusion, I thank you for the opportunity to testify, and I'm happy to answer any questions you may have.
Thank you, Mr. Lazo. I do have one question. I think a major area of focus for the legislature over the past 2 or 3 years since the beginning of the pandemic has been making sure that no matter where a veteran is from in Massachusetts, they have access to use our soldiers' homes and to get a bed there. Can you talk about some of the reforms under your leadership for those intake procedures to make sure that, it's just not that the greater Holyoke or the greater Chelsea area that's veterans are able to utilize the homes?
Yes, thank you for that question, Senator. We've taken a good hard look at our admissions process, and we've standardized the process so that veterans of any area, any community in Massachusetts are eligible. As long as they meet the eligibility as based under the law, we will review and accept any veteran from any part of Massachusetts.
Are you seeing applications from across the state, or is it, kind of regionally centric?
Most are regional, mostly, Worcester West. Mm-hmm. Nothing really east of Worcester at this point.
Understood. Thank you.
Let me just add, as a part of Chapter 144, which many of you guys played a role in, the governance had changed. And so part of what you were suggesting there is that there was a certain level of patronage or parochialism that existed in these respective homes. They had been previously, the superintendents had been appointed by a certain board of trustees. I think at the time it was about 7 people. Now, given Chapter 144, that process has completely changed. Now, our executive director of Homes and Housing will be running that statewide council that will be effectively in charge of selecting superintendents. And that's consisting of 5 members from Chelsea, the board of trustees, 5 members from Holyoke. It's 4 selected by the governor, 3 by the HHS secretary, and I think you're a voting member as well? Mm-hmm. And so that's going to add, a certain level of professionalism, but also just a widespread of diverse opinion and thought throughout the Commonwealth.
Thank you, Mr. Secretary.
Yeah, the other thing that I would, the other thing that I would add is, as part of the Chapter 144, and thank you very much for the leadership in adding this, there's a provision for addressing specifically geographic accessibility and equity to quality care. So that is one of the things that we'll be looking at, developing mechanisms to better understand that, and we're looking for both of our homes and their local boards of trustees to help be our emissaries, as it were, to all of the VSOs and to the geographic areas that each of them is representing. So we're hoping to do that and to continue to increase a better understanding of the needs for access for services and how best to provide those services to our veteran populations wherever they live in the Commonwealth.
Thank you.
Matt.
Rep. Moratori.
Yeah, thank you very much. Appreciate that. First of all, congratulations, Mr. Secretary, the new position. I'm glad to see you in that. As a nursing home administrator licensed in Massachusetts, I've got a comment and a question. The question is, are the folks running these 2 homes now licensed in the Commonwealth as nursing home administrators, or is that going to happen?
We are both licensed at this time.
Excellent, excellent, excellent. And I applaud you for your staffing levels. I'm not sure how you're doing it, but that's unheard of to hear staffing levels like that. But I'll tell you, that equates to good care, so I'm sure that's going on. I applaud you for everything you're doing. It's unfortunate the media doesn't pick up on the good things that happen in the soldier's home. But I applaud you for what you're doing. You should be, extremely proud of your staff and what they're doing. So thank you very much for what you're doing.
Thank you.
To your point, Rep., as many of you know, with Chapter 144, that was part of the statutory change that both superintendents had to be nursing home administrators. And so that's currently ongoing, and we're in the process of getting DPH and CMS certification as well. And so we're beefing up our professionalism, and I hope that'll translate to better care. I'm confident it will.
Great, excellent.
Can you repeat what you just said? DPH and what?
DPH and CMS, DPH
licensure, CMS
certification, yeah.
And Mr. Engel, I want to invite you to provide your testimony, too.
Okay. Thank you. Good morning, Chair Cronin, Chair Lenatra, and all members of the Joint Committee on Ways and Means. My name is Robert Engel, and I'm honored to be here as the Acting Superintendent of the Veterans Home in Chelsea and the Executive Director of Veteran Homes and Housing. Thank you for the opportunity to appear before this committee and testify on behalf of the Veterans Home in Chelsea. Governor Healy's fiscal 24 budget proposal of $49 million will fund the staffing and operation of our newly built community living center and our domiciliary residential program. We are actively planning our move into the Community Living Center, or CLC, towards the end of spring. Our entire team is working together as we embrace the Veteran Administration's small home design concept of supporting care and services in a truly home-like environment. The Veterans Home in Chelsea opened in 1882 as the second veteran home in the nation. Since our founding, the Veterans Home has continued to provide care and services for generations of Massachusetts veterans. We are proud of that tradition, honored to be part of the new Executive Office of Veteran Services, and committed to our mission of providing care and services with dignity, honor, and respect for our veteran residents and our team members. Veteran residents in the long-term care facility are provided skilled care from our nursing, ancillary clinical, and medical teams. In our domiciliary, veteran residents receive support from residential services staff, clinical and supportive services from nursing, social work, and the medical team who work with and respond to each veteran's unique needs. Our goal in the domiciliary is to support residents and facilitate their safe transition back to the community whenever possible. We actively collaborate with local partners such as community housing authorities, employment providers, community leaders, healthcare providers, and educational institutions to assist us in strengthening our residents' ability to return to the community. The Veterans Home in Chelsea is focused on our residents. Our 325 team members care for 200 veterans in our long-term care and domiciliary programs. Our team members believe in their service and are honored to provide excellence in all that we do for the veterans we are privileged to serve. Diversity, equity, and inclusion are important to us. And we are pleased to say that our team is representative of our greater community, with 31% of our workforce identifying as Black, 16% as Hispanic, 2% as Asian, and 61% as women. We are also proud of our partnership and collaboration with labor and the 8 unions who represent our team. 68% of our staff have been with the Veterans Home for 5 or more years, which is a testament to the commitment and dedication of our staff. We are appreciative of the tremendous support we receive from the Commonwealth. This support allows our Veterans Home to establish the standard of care with an average of 10.2 hours of direct care per patient day in our long-term care setting in the most recent month. Our staff have remained committed and dedicated to our residents throughout these challenging times of the public health emergency. They have exhibited an inexhaustible work ethic and with true commitment to those we serve, while maintaining the utmost concern and vigilance for infection prevention and control. Our infection control team is led by our medical director with support from our infection preventionist and occupational health nurse, along with our entire team. Our team members are continuously learning and improving through both training and education programs and the consistent oversight and in consultation with the Department of Public Health, Infection Control, and Prevention Nurse Advisors. Our new Community Living Center is located on the campus atop iconic Powderhorn Hill. It will serve the Commonwealth's veterans as a state-of-the-art long-term care facility. The thoughtful building design will provide an uplifting and pleasant environment for our residents. It is designed to capture daylight and provides panoramic views of downtown Boston and the harbor. Not only a model for dignified long-term care veteran care, our new Veterans Home will be a state-of-the-art, resilient, and sustainable building that meets current and future needs for our veterans in Massachusetts. The existing Quigley Hospital building will be taken down when the new home becomes operational, facilitating the final development of a full 7-acre site into an accessible landscape while restoring the enhancing Powderhorn Hill as a public amenity. At its core, the Community Living Center is design is about creating a home for our veterans. It is based on the guiding principles of autonomy and dignity in a home-like environment, with enrichment activities, socialization as a goal, with space for family and friends to visit, including a kitchen for group meals and a den for spending time together. There will be 2 14-resident homes on each floor, called neighborhoods. With 11 homes, we'll have a total of 154 total rooms for our veterans. We'll also be developing new focused programming for our Alzheimer's and related dementia residents. We thank the legislature and our colleagues in the executive branch for their vision and support of this truly amazing facility, which will facilitate nothing short of transformational care and services for our veterans. DCAM has been with us every step, and we are indebted to their oversight and management of the project. Our entire team at Chelsea, with the support of the Executive Office of Veteran Services, is excited and focused on enhancing our systems and processes. We are currently pursuing full CMS certification and DPH licensure for the 150-bed CLC. We will also continue to grow our human resources through aggressive hiring efforts, represented most recently with our hiring event that drew over 100 job seekers. And year to date have hired over 30 employees and are on track as we strive to grow our team to 400. We are very proud of our team at Chelsea and the excellence in care and service that we provide. There are several external regulatory agencies and accreditation organizations that come on site and perform rigorous standard-based inspections of our home. The Veterans Administration completed their annual survey in January, and while the results do include areas that we can improve, there was no harm noted at any of the citations. In addition to the VA, we have had Massachusetts DPH on site at the home conducting infection control and prevention consultative visits. Each visit includes touring of the facility. Since December 2022, we have had over 20 visits, each with positive results and helpful recommendations and observations to further enhance our programs. Another indicator of quality can be measured in the demand for our services. At present, we have a waiting list for both our domiciliary and our long-term care facilities. We are working with 15 families for the domiciliary and 90 in long-term care. We also have a continuous program of conducting satisfaction surveys monthly. Surveys are conducted on our behalf by Pinnacle, an independent third-party agency. We are pleased to share that Chelsea is a recipient of their annual Customer Experience Award with recognition in 10 areas noted for overall satisfaction and customer experience, dignity and respect, nursing care, quality of food, cleanliness and individual needs, responsiveness to problems, activities, and communication. One of the benchmark awards from Pinnacle is that we are recognized in the category Recommend to Others. This is truly an indication that those who know our veterans' home in Chelsea the most, residents and their loved ones, will recommend us to others and is an overall indication of their trust and their satisfaction in us. In addition to striving to provide excellence in care, we are also focused on social and emotional well-being of our veterans. We offer a very robust calendar of recreational programs with daily opportunities for our veterans to be engaged in purposeful activities. The Veterans Home in Chelsea is fortunate to have community partners from all over the state. Our leadership have attended dinners, award ceremonies, women's veterans network events, stand-downs, and several other community events throughout the year, allowing us to engage and educate on veterans' benefits and the role of the Veterans Home. And we are very pleased to start opening back up again, and are thrilled that several of our community partners were on site again over the holidays and for weekly bingo and other much appreciated events, including off-site trips to Old Ironsides and deep-sea fishing trips. We are very positive about the future of the Veterans Home in Chelsea. The home is working towards becoming certified by the Centers for Medicare and Medicaid Services, CMS, and licensed by the Department of Public Health as a nursing home. We've been working diligently with our own staff, supported by an outside expert consultant, and will be submitting our applications as soon as possible. Another important initiative that we have underway is the implementation of an electronic medical record. We have contracted with an EMR vendor and will be moving forward with implementation soon. Our team is very excited to start in the near future. As highlighted earlier, we will soon be moving into the CLC, a state-of-the-art facility that will support the provision of tomorrow's care today. In addition to the domiciliary side of campus, we are embarking on, with DCAM and their partner Penrose, on the domiciliary campus redevelopment project, which will lease approximately 8.7 acres of the campus to create independent veterans preference housing and supportive services. The phased redevelopment project will update the campus through a combination of rehabilitation and new construction to better meet the needs of veterans and their families. It will provide updated, affordably priced housing options for veterans and their families. The new development will include 220-plus units of mixed-income affordable housing with supportive services with 100% veterans preference, and support for the continuance of the unique mission of providing housing and services for our veterans in the Commonwealth. The Veterans Home in Chelsea is looking forward to our future, to the anticipated opening of the Community Living Center, expanding our workforce and our veteran resident population, our community outreach, and being part of the new Executive Office of Veteran Services, all of which will allow us to continue our mission, a mission we are honored to live every single day. Thank you for the opportunity to testify. I am happy to answer any questions you may have about the home and the FY24 proposed budget.
Thank you, Mr. Engel. Representative?
Thank you very much to the panel for your testimony today. And Mr. Secretary, congratulations to you. We were sorry to lose you in the legislature, but we're happy to see you on the other side. And we know you have a greater appreciation, I think, for how the budget process works. And so we're excited to be working with you. In terms of our two homes, can you walk us through the process when somebody submits an application for available bed space? How long does that process take on average? And so how long does it take from soup to nuts to get somebody who submits, goes through the review process, and then gets an available space in one of the facilities?
I guess I could speak for us. We are on a first-come, first-served basis. A family will submit either electronically or physically appropriate documents which will support their application, and we then work forward with an interdisciplinary team in reviewing those applications and ensuring that the individual meets all eligibility criteria, both clinically and by being a veteran, et cetera. And we work through that process to offer beds as they become available.
Do you know what the average wait time is for Chelsea?
I'm sorry that I don't, sir.
For Holyoke, I would estimate 6 months.
6 months-ish. So, 144, I think, is a great improvement, especially the way that the process works, and I think it's going to serve veterans much better as time goes on. In terms of our bed capacity, so how many available beds do you have? Is the mission always, obviously, once those spaces become available, to fill them? But I guess from this committee's perspective, we always have an eye not just on the here and now, but what happens down the road. So in terms of projections for veterans that are cycling into the age bracket and then the need for available beds, where do you see our bed capacity going in the next few years? I mean, when's our worry point, I guess, for available bed space for veterans?
I guess I could speak. There were studies done within this decade that talked about the demand for services, demand for long-term care of our population, and there's also studies that are done talking about long-term care and the need for long-term care, and the numbers sort of go in different directions. I think that our two homes, our flagship institutions, will always be fully subscribed. I think that they will continue to provide the best of care possible for our veteran population with an understanding and an appreciation of the unique needs of our veterans. And we will also be embarking as part of the work of the council going forward, as I commented earlier, on understanding the needs of our veteran population across the Commonwealth and the needs for addressing equitable access to high-quality care and services. We're not sure exactly what that means, sir, but we do know that we will be exploring that and as part of the portfolio of issues of concerns that we look at as part of our council work.
I appreciate those comments. I think, one of the challenges, one of the worries that we have as legislators is we see what's happening in the healthcare industry, particularly in our nursing home population, and it's no different in the veteran population, I imagine, as well, is that to make sure that not only that we can maintain, but we can make sure that we have the availability as those numbers ebb and flow over time. So I appreciate that the state's going to keep an eye on that, and thank you for that. Mr. Secretary, I know you've only been there a very short period of time, but I know you have your finger on the pulse of a lot of issues relative to veterans. One thing that's popped up in our territory in central and western Massachusetts has to do with VSOs, and in some cases the lack thereof. coming into municipalities, being able to kind of pick up the responsibility of what a local municipality needs in a VSO to recruit and then retain. Have you seen that in any other parts of the Commonwealth relative to openings and availability for VSOs in various municipalities across the state?
Well, thank you for the question, Representative. To your first question, let me just also add some context as well. The veteran community in Massachusetts is also decreasing, right? And so, as Mr. Engel said, while the concerns for long-term care are increasing, the community is actually decreasing. With respect to VSOs, you're absolutely right. There is a concern with respect to equity, engagement across the Commonwealth, particularly in the more rural parts of the Commonwealth. There is a desire in the executive office to beef that up. We have a director of operations who kind of oversees programming, primarily Chapter 115 and some of the annuities. But we've also decided to beef that up as well. We just hired actually a deputy director of operations to assist with that effort. And we'll be working closely with the VSOs. In fact, we meet with them once a week. I plan myself attending those meetings as well to engage them. We also have a training with them once a year. But without question, you're absolutely right. The mission of the VSO, the mission of Executive Office of Veteran Services, it's critical that we are in communication, that we're working closely with one another, and that our goals and our objectives are aligned.
Great. Thank you very much. Appreciate it.
Thank you, panel. It's really nice to hear from you today. I wanted to talk a little bit just about the applications for full DPH licensure. That's something that I hadn't heard about, and it's really interesting to me. I'm vice chair of the Joint Committee on Elder Affairs, and we're looking really closely at state oversight of licensed nursing facilities and long-term care. And so I'd certainly like to reach out to you after this just to get your impressions of this process and also ensure that the bills that we're going to be considering in our committee are mindful of any nuances that you all are engaged in the process with DPH. And I guess that would be one of my questions is, in the licensure process, are there particular components of your vision for nursing facilities that differ from others in the state?
I don't. Thank you very much for the question. We've really enjoyed very close partnership with the Department of Public Health, with the Division of Licensure and Certification. We've had ongoing series of meetings with them, and they've been incredibly supportive as we've gone through this and navigated through this process, both for DPH licensure and for CMS certification. So truly, it has been a level of partnership and support that we've appreciated. And to the second part of your question, I don't know that we necessarily have thought through that question. We know that services mindful of trauma-informed care, PTSD, the unique needs of our veteran population are things that we are certainly very mindful of in the services and care delivery that we provide, and that would be something that we'd be looking at also at the council level as we try to look at accessibility to access to these services across the Commonwealth in both traditional long-term care facilities and non-traditional ways through the full continuum of care services that are available for our veterans.
And from your testimony and also the materials that the administration provided in advance, is it right that these are private? Are they private rooms, or how many residents would be in a nursing facility room? Is it
in Chelsea, they're all private rooms, and I believe the same is true in the design.
In our new building, we'll have 234 single rooms. We will have 11 rooms that can be doubles if the veteran so chooses to have a roommate.
Thank you very much.
As you can imagine, from an infection control perspective, this makes things significantly easier to control the spread of things that can transmit. But we're excited about it, and we're happy to follow up with any other information with respect to licensure. It's something that we've been talking about the last couple of days, and it's quite a bureaucratic process, but it's important. I mean, we really focus on how do we standardize these homes, and as you may have heard, there is some differences between how both homes are kind of managed, and Mr. Engel's role as the Executive Director of Homes and Housing, who provides not necessarily oversight with respect to the two superintendents, but a level of collaboration. We're really focused on how do we standardize processes, how do we make things much more efficient for the veteran and their family so they can experience the process as streamlined as possible.
Thank you all very much.
Yes, sir. Thank you, Chair. I think this is fantastic. all of us here appreciate our veterans. Many of us come from military families. Secretary, I mean, what a background you have. A doctor, Army major, a Peace Corps, legislator. It's fantastic. You should be at cabinet level. I'm very proud of that. And what you're doing is life-changing. I just have a couple of comments and then a question. Massachusetts should lead the country. This is where freedom began. We should do everything that we can for our veterans and their families. They shouldn't be living in broken-down buildings. They should be in the best that we can offer. I've been to Chelsea. The new building is incredible, even just to look at. But one thing I saw there was the love and the passion given to the veterans by your people. The employees, they love the veterans, and I noticed that. That was very special to me. The 115 Chapter 115 safety net, very important. Even on Cape Cod, it's used often. The VSOs talk about it all the time. The annuity programs for disabled vets, and even for, Gold Star families like mine. We appreciate that. Female veterans. The VSO situation where we want our veterans to be able to go to one person and have that person navigate the entire state system and the federal system. I've seen it work. It's fantastic. The question I have is the SAVE program and the mission to stop veteran suicide, right? My son was killed in Afghanistan in combat. 7,000, I think, in America's longest war. More than that have taken their own lives when they come home. And that's horrible. So we have an 11% increase thanks to the governor in the proposed budget. That's fantastic. What can we do more to help our veterans that made it home to overcome PTS and anything else that is troubling them that would lead them to take their lives?
Well, thank you for the question, Representative, and thank you for your sacrifice. I mean, there are few people in this room that respect and honor the veteran, the military community more than you do, and I appreciate your leadership on those efforts. With respect to SAVE and a whole host of programs that work with PTSD and mental health issues, I concur with you. We can do more, we should do more, we will do more. What I've learned in my 3 weeks here is that although we're doing some work, we can do it more efficiently, but we can do it in partnership and collaboration. My first visit as secretary was with Home Base, program based out of Charlestown, that really focuses on this, that has invested in this, and that has created a number of innovative programs. And as a physician who oftentimes takes care of folks suffering from the trifecta of mental health, substance use, and homelessness, which are incredibly challenging individually. Nevertheless, if a veteran is certainly dealing with three of them, it's important that we support and engage these partners. And in this budget, there is an earmark going to them, $2 million, that's been there for a couple of years, and we're looking to beef that up. But it was important to meet with Home Base and General Hammond my first Wednesday in office. Say, listen, we're going to work with you closely in collaboration. They've played a tremendous role in supporting veterans, providing services, and whether it's them or whether it's another nonprofit across the Commonwealth, the Cape, I was just in the Cape last week visiting Cape and Islands Veterans Outreach Center, and effectively we've doubled their resources over the past year. We gave them an additional $500,000, and with that they were able to significantly expand their food program. They're investing in veteran housing, and we plan to do the same. I was telling them, and I'll tell you, and I'll tell each and every one of you, if there's a dollar bill out there in D.C., we plan to go get it. We're hiring grant writers, and so we're aggressively going to be getting as many resources as we possibly can to provide the services that you so eloquently described.
Thank you, sir.
Thank you.
Thank you.
Mr. Secretary, I just want to thank you and the rest of the panel for your testimony today. We're at about an hour, but we're all really grateful for the work that you take on. and it's incredibly impactful, and the state really needs your leadership. So we wish you good luck and much success in your new role, and go Army, beat Navy.
Will the folks who are remote be able to ask questions?
Thank you.
What's that?
Oh, someone on Zoom had a question. I thought they were on Zoom. Thank you. We're going to move right along to the Department of Transitional Assistance with Acting Commissioner Mary Sheehan. Welcome.
Good afternoon, Chair Cronin, Chair Sinatra, and distinguished members of the Joint Committee on Ways and Means. My name is Mary Sheehan. I'm the Acting Commissioner at the Department of Transitional Assistance. I appreciate the opportunity to join you to discuss the work of our agency and how the Governor's fiscal year 24 budget proposal supports our efforts to serve our most vulnerable residents. Over the upcoming months, we are preparing for the end of the federal administrative flexibilities related to the public health emergency and supporting our clients through termination of the extra federal food benefits that they have come to rely on. The Healey-Driscoll administration's fiscal year 24 budget proposal will enable the department to advance the agency's priorities and build on recent successes. This past year, the Supplemental Nutrition Assistance Program, SNAP, the Transitional Aid to Families with Dependent Children, TAFDC, the Emergency Aid to the Elderly, to Disabled and Children, EAEDC, all have seen continued increases in the number of households served. And we expect to see continued high caseload levels as the administration continues work on the Integrated Eligibility and Enrollment Project. About 640,000 Massachusetts households receive food assistance through SNAP. That's 43% higher than pre-pandemic levels. And DTA's economic assistance or cash caseloads continue to be impacted by state-level legislative changes that expanded eligibility, including a 10% increase to the income thresholds this year on top of previous year's increases, as well as the elimination of the asset limits for these programs. TAFDC and EADC caseloads are up 30 and 47% above pre-pandemic levels, respectively. To date, DTA has managed the growth in caseloads with the operational flexibilities that federal waivers and the public health emergency have provided, as well as through overtime funded through ARPA. The department is preparing for the end of these flexibilities by increasing staff hiring to help manage the higher workloads, and separate from the House 1 budget proposal, a fiscal year 23 supplemental bill has been filed by the Healey-Driscoll administration to better support DTA's staffing needs and reduce the need for overtime long term. DTA respectfully requests full and expeditious passage of this bill. DTA strives to maintain a high level of customer service even while facing these increased caseloads. While DTA offices are open across the state to provide in-person services, the majority of our clients choose to do business with us through our enhanced online and telephonic platforms, including DTA Connect, our mobile app, and online portal. This is particularly important for the over 300,000 clients with disabilities and 236,000 seniors for whom travel to our offices may be difficult. DTA Connect is now available in Haitian Creole in addition to English, Spanish, Vietnamese, Portuguese, and simplified Chinese. DTA also recently added new features and security improvements to the mobile app. All reception areas now have pictorial communication boards to support clients who are deaf, hard of hearing, nonverbal, or have limited English or verbal proficiency. And we recently procured a new interpreter services vendor through which the agency has expanded its video remote interpreter access to all of our offices. So overall, more than 300,000 clients with disabilities benefit from our inclusion of universal design principles in local offices, promoting an accessible and equitable client experience. The administration is committed to promoting food security in the Commonwealth and strengthening its local food systems and economy. The 2023 Consolidated Appropriations Act created a permanent summer EBT program that allows for $40 in food benefits per month for eligible children. The fiscal year 24 House 1 budget proposal includes $500,000 to support the necessary systems changes to implement this new program in time for the summer of 2024. Half of that cost will be reimbursed by the federal government. I especially want to thank the legislature for supporting the $130 million request for the administration's fiscal year 23 supplemental budget that creates an off-ramp from the extra SNAP emergency allotments, a benefit that federal government provided in response to the pandemic that significantly increased each household's monthly SNAP benefits. This extra federal food support ended effective February of 2023. Another important part of DTA's work is its support of our clients' economic mobility. Through DTA's Pathways to Work program, the department is engaging with families to connect them with employment, education, and training that lead to meaningful, tailored opportunities in high-demand careers. Overall, the administration's fiscal year 24 budget proposal includes more than $29 million to support this work. This includes an investment of $3.25 million, up $1.5 million from fiscal year 23 for the Massachusetts Office for Refugees and Immigrants, ORI, to enable them to serve the influx of immigrants to the Commonwealth through their Employment Support Services program. Funding at both DTA and the Massachusetts Rehabilitation Commission, MRC, also supports expansion of our ongoing partnership, Empowering to Employ, to engage DTA clients with disabilities in vocational rehabilitation and job placement services at MRC. I want to thank Commissioner Wolf and her team at MRC for their partnership. Finally, and unfortunately, we have seen a substantial increase in criminal actors who are systematically targeting low-income households and stealing their benefits, or using stolen identity information to initiate fraudulent benefit applications. While DTA has implemented multiple strategies to protect clients and their benefits, we need resources in order to successfully slow down or stop these thefts. The administration's budget proposal includes $310,000 to purchase new functionality from the state's EBT vendor to allow clients to remotely lock or unlock their EBT cards in the vendor's mobile application. We urge you to support the funding request for this initiative. I also want to thank the legislature for supporting the $2 million request in the administration's fiscal year 23 supplemental budget that supports clients who had their benefits stolen between April 1st and September 30th of 2022. This funding will support a significant number of clients who are not covered under the 2023 Congressional Consolidated Appropriations Act for reimbursement. Thank you all for your continued partnership in serving the Commonwealth's most vulnerable residents. I look forward to working with you as we navigate the end of the pandemic flexibilities and extra food benefits while continuing efforts to protect our clients from scams. I'm happy to take any questions you may have. And I failed to introduce my CFO extraordinaire, Rachel Goldstein.
Welcome, Rachel.
Sorry about that.
Thank you, Commissioner. Any questions from the committee? Senator? Oh, yes, please.
Please go ahead, Senator.
It feels cool together. I hope this is on. Thank you so much, Commissioner and CFO. I actually have quite a bit of comments and questions. I came prepared today.
Okay.
I have the honor of serving the 2nd Suffolk, which are neighborhoods of Hyde Park, all the way to the South End. And so many of my constituents actually either receive SNAP benefits or TAFTC benefits. And so I'm going to start. So nationally, TANF or TFTC in TAFTC in Massachusetts has experienced a drastic decline, in some cases to reach the families who may need it the most. Access to transitional aid has been increasingly difficult, particularly for some of the families in deep, deep need in our communities. We know at the federal level, policymakers have not increased the TANF block grant since its inception. And as a result, our aid limit is kind of low. The maximum benefit for a family of 3 with no income currently is $783 a month, and the federal government defines deep poverty as making less than $1,036 a month for a family of 3. Is there a desire from the department to lift these income thresholds and asset limits higher than what they are and increase the grants? I know that you mentioned there's been a 10% increase in income and an elimination of asset limits, which is incredibly important. So that's my first question to desire. The second is House One's proposed EAEDC line item, sorry for the acronyms, but I'm trying to make things shorter, does not include language requiring advance notice to the legislature before the administration cuts benefits or makes changes in eligibility. So I just have a second question. Do you plan to provide notice or increase that capacity before you make cuts to programming? And then the last question in this part of the questioning and comments. As of March 2nd, we know that the extra COVID food funds have ended. This means that over 640,000 households in Massachusetts are stripped of the benefits and have received their last extra federal SNAP payment. And we jumped in there in the supplemental budget to support 40% of that, which was at a minimum of $95 per month for households. Are there any plans to ensure funding is given to those families who come to rely on these benefits? I know you're creating an off-ramp, but $95 isn't a lot of money, but people really, really need it. And so we've come in and kind of saved the day a little bit with the 40%, but after that runs out, families are still going to be hungry. And so we're just trying to figure out how do we actually meet the food security needs. So,
all right, thank you,
hope
Senator.
I got that. Sorry.
That's fine. And my short-term memory issues, I had to write down the questions. But yeah, nationally, TANF caseloads are up, but in are down. Sorry, but in Massachusetts, they're actually up, and that is due to the increase in the benefit thresholds. Because when the benefit thresholds increase, it actually increases the eligibility thresholds as well, and the asset limit elimination really. Brought on more cases in both TAFDC and EAEDC. And your question in that regard was, regarding the governor's budget and increasing benefits further. Right now, our focus is on transitioning folks through our employment services, our Pathways to Work program, trying to get them to a place where they have some economic mobility, and the governor's budget does include 2 initiatives. One investment is to help us streamline the process to issue a $300 infant support payment for any eligible child or family with a newborn for the costs of cribs and supplies for a newborn. So that is in the governor's budget, as well as stipends for participation by clients in our advisory boards to get the client voice at the table. We feel like that will help us in terms of policies and procedures to understand from their perspective what they're experiencing and how we might be able to help. As far as the notice before any program changes, I mean, generally speaking, if we were to be looking at a deficiency in any of our caseload accounts, we would prefer to work with the administration to see if there's an appetite and an availability for supplemental funding before we would make any changes to eligibility or benefit levels. And that's generally been our approach. We would work with EOHHS and the administration, and then if we were to, absolutely need to make any changes, we would work with you all as well. As far as the emergency allotments go, we've done a lot of work on this in terms of outreach, making sure that everybody is aware that these extra benefits that have been issued for 3 years now that have really helped, I think, not just the families, but quite frankly, the Massachusetts economy. These were federal benefits that helped, that brought everybody's payment level up to the maximum for their household size. And with those being a federal benefit and the kind of surprise early ending of those that came through the economic bill, I can't remember, the Consolidated Appropriations Act, that federal bill, that kind of took us by surprise that it was an early ending. So that is where the administration, stepped in and filed the funding, and thank you so much for supporting that. That allowed for the ramp down off of that benefit. We don't control what the federal government does. We did work with them in trying to get their attention on this because it really is a significant issue for a lot of our families. Well, for all of our families, but a lot of the families in Massachusetts. So what we have been messaging is really important. Certain of our seniors, for instance, can increase their base benefit by providing us with information about their medical costs or other deductions that can help to increase the benefit level that they receive on a monthly basis after this, the 3-month 40% benefit. So that will be critical. We've been kind of marketing that every chance that we can, talking to our clients, talking to our sister agencies to make sure that folks contact us, give us that information. We've made it very easy for them to do that. They just have to fill out a form that says that what their medical expenses are, and that also includes, over-the-counter things. So there isn't a real hardship for them to do that, and that will help a lot. And the other thing we're doing is providing them with information on where the food banks or other resources might be, if they need housing assistance or any other type of support. We're providing them with information so that they can try to find the help that they need.
Thank you. And I have 2 more questions, but you don't have to answer them today because I know my colleagues need to get to this. I had a real story about SNAP theft in my district where a family, a working single mother, lost $2,000 over a weekend just by going to a local store. She didn't drive, so she didn't go to a Stop and Shop or Shaw's. She just went into a small bodega, and over the weekend lost her not only Social Security benefits, but lost her SNAP benefits because of phishing with the machines that she utilized. And I'm really happy that you have the $2 million in H1 around replacing stolen benefits, but I'm concerned there isn't really wraparound language to make sure that people are fully reimbursed. And so I'd love to see some language change to make sure. She called my office almost desperate, in tears around that she couldn't live another day without these benefits. And so it's incredibly important that they get reimbursed in a timely manner when it's no fault of their own. And the last question or comment is about the cliff effect. I think most of my colleagues have heard from your constituents. If you haven't, as soon as they get a job, And even if it's $20 more a week, sometimes they're very scared that it determines that they should be getting less benefits when really, in reality, they need a sustained benefit level, even though they've gotten a new job. Many of them are working jobs that still don't pay them enough. In Boston, the median income in my district is $17,000 to $33,000 that people are making a year, and it takes over $52,000 a year just to survive. And I'd like to say it's probably close to 100,000 in the city of Boston. And so I'd love to know about if you guys have gotten data around how many folks are actually impacted each year with DTA, with cliff effects, that actually increased money and getting a pathway to employment actually decreases their funds, and how that has impacted them. So thank you for both sharing.
Okay. And you're good with holding on those?
Yes.
Or, okay.
I got it on my colleagues. Sorry I came prepared today.
Thank you, Senator. Thank you, Senator. Representative?
Commissioner, thank you very much for your testimony here today, and we appreciate all that you and your team do. We know how important and valuable transitional assistance is to people all across the Commonwealth of Massachusetts. I'm going to expand a little bit, actually, on what Senator Miranda was just talking about relative to fraudulent claims, because I think we've all seen in our offices similar cases where you have constituents that communicate with us that say, I've got a situation here where I was supposed to have a particular amount of resources here and now they're gone, and I think I'm the victim of some sort of fraud. Can you define for us a little bit how those fraudulent claims are processed? In other words, what categorizes a fraudulent claim? Somebody whose identity was stolen, someone whose benefits were stolen, somebody that submits a request for transitional assistance but gets denied. How do you classify that? And also, how do you quantify it in terms of the impact that it has? So financially, what kind of number are we talking about for fraudulent claims financially?
Yeah, so what's happening is that our clients are using their EBT cards in, their local neighborhoods shopping, and fraudsters are putting a device right on the POS or the ATM machines and capturing their card number and their PIN. And then what they're doing is cloning the card and using it to transact the benefits. So they're stealing in, these benefits from the client accounts. It's coming at a very difficult time when we're, sending the message, the emergency allotments are ending. Try to stretch those SNAP dollars, hang on to them, and then they go to the store and they're wiped out. So this is a real national challenge. It's not limited to Massachusetts. In fact, we're seeing a lot of the transactions where the benefits are actually being stolen are out of state. They're not even in Massachusetts. And so for us, what we are doing is we're tracking that. We have to contact the client and verify if we have to do a little bit of investigation, put it that way, to make sure that this is an authentically, stolen benefit. If it's a cash assistance benefit, then we are reimbursing it. If it's a SNAP benefit, those are federal, and we are not. We have no authority to reissue those benefits yet. The consolidated, I can never remember the name of that bill. Consolidated Appropriations Act. The federal bill actually authorizes replacement, but it limits it to any benefits stolen after October 1st, and we had almost 2 million stolen, actually 1.5 million stolen prior to that we know of. And it also limits the amount that the reimbursement can be to up to 2 months of their benefits. So if they were saving their benefits because of the emergency allotments ending, they will be limited in what gets reimbursed. The bill that I believe is going to be going to conference, I don't think it's in conference yet, has 2 different versions of that. The House has, you guys have, it aligns with the governor's proposal, which aligns with the federal reimbursement, and the Senate version has more of that wraparound that Senator Miranda was talking about, where it tries to get to the full stolen benefit amount. So we'll implement whichever bill comes out or whatever compromise happens through that conference committee, and we'll try to get those benefits out as soon as possible. We are already, working on the requirements for the systems changes to be able to do that. It will take a little bit because of the uncertainty on the bill as to what programming we need to do. But rest assured, this is this and the emergency allotments are high priorities for the department, and we will do everything we can to get those benefits out as soon as possible.
Thank you for that. That $310,000 that you had referred to before relative to the mobile app where somebody can lock or unlock, is that supposed to be a super effective tool to try and reduce this fraud or somebody stealing identity? Can you tell us just quickly how that works?
Yeah, it should do that definitely more effectively. So replacing changing your PIN, which is what we've been messaging our clients. It works right away. However, if that client goes to another location or the same location and the information is stolen again, they're going to have their benefits stolen again. So what the locking and unlocking will allow them to do is only unlock their account at the point that they want to transact a benefit and use them. So they'll be able to access the benefit and then immediately lock it down. Could something slip through in that short time window potentially? So I can't guarantee it'd be 100%, but it will definitely be hugely effective for clients.
And last question on this: so somebody goes, they go POS identity gets stolen when they're doing a POS or an ATM. How do you know that it's fraudulent? Is it because the individual reports it, or is it because it's something else in your system that you pick it up? So I'll take, as an individual, I walk in and I go and I buy groceries, but I'm not necessarily paying as close attention always on what I spend on the bottom line. My wife's a lot better at it than I am. So when she goes through the bills, she may see and bring this back, but I don't know if I've, spent $100 or $50 or $70, and I imagine that some individuals that utilize the electronic benefit system may not even be aware of the fact that they've been hacked or their identity's been stolen or they have resources taken out unless they're keeping really solid track of every single one of those transactions. So how do you know that fraud is taking place when somebody may not be on top of it as an individual collecting the benefit?
Right. Yeah, no, that's a good question, and we have worked. We just procured an analytics tool that takes a look at where there might be, rapid transactions happening out of state, which is a clear indication that, somebody has cloned a whole bunch of cards. And so we are, we're implementing that so that we'll be able to locate any clusters like that. And as far as the clients are concerned, I think, the thinking is that for most of our clients, because they're so reliant on this benefit, they are very aware of their balances and they are tracking it. And, we have clients come into our offices all the time upset about this issue, and rightfully so. And what our staff will do is actually take a look at the transactions, print it out for them, have them, take a look, and you can see it on the transaction that, they've been in Massachusetts shopping on the same day that something is transacted in Texas. So we're able to verify that way that this is fraudulent, and we'll, like I said, if it's cash, we'll reimburse it, but if it's SNAP, we will be. We will be, hopefully soon.
Thank you very much.
Thank you, Representative. Before we get to Rep. Pease, I just want to address my colleagues on team. If you have a question, could you please text either myself or Senator Cronin, and we will recognize you with a question. Thank you. Representative.
Thank you, and appreciate it, Commissioner. So yesterday I was having a conversation with our Council on Aging person, and she was talking about the food from the Western Mass Food Bank and that they did not receive any protein at all with their latest shipment to provide food. And she also mentioned that homelessness and mental health issues for the seniors are on an increase quite a bit over the last few years. But have you seen that the food banks, like she said, we couldn't even get any peanut butter, where it's always a nice, staple to have on hand. And I'm not sure if you're seeing that across the state or if that's a Western Massachusetts issue right now. But the food
Yeah,
banks, are they having issues?
Well, we don't administer anything with the food banks, but we do have, relationship with them. I'm sorry, I can't really speak to.
I just figured if you maybe heard something that
Yeah,
coming from them that they're really
hadn't.
short or anything. Okay.
Yeah, no, but we can definitely look into that.
Thank you.
Thanks.
Thank you. Rep. Beal, and then we'll get to Rep. Haggerty.
Good afternoon, Commissioner. Thank you for your testimony and also for everything you and the department do to help the most vulnerable in our community. Just wanted to put something on your radar to start a conversation beyond today's hearing. I've recently heard from providers in my district who have had issues accessing and navigating DTA's funeral and burial assistance program, which helps families make final arrangements for their loved ones with dignity and respect. So I know it's not specifically something that we expected to talk about today, but just wanted to let you know that there are issues out there and hope to work with your team to resolve those so that people can make arrangements for their loved ones during especially difficult times.
Sure, and I can have staff reach out if that's appropriate. I mean, we want to make sure that we're helping the funeral homes. If there's a specific issue, we just need to figure out what's going on and resolve it. So I'm happy to work on that with you.
Appreciate that. Thank you.
Okay.
Thank you, Rep. Beal. Rep. Haggerty?
Thank you, Madam Chair. Commissioner, what type of steps are we taking to claw back some of this money that's been fraudulently utilized? And what steps are we taking to go after some of these bad actors if, in fact, this is something that's going on at a higher rate than certainly pre-pandemic?
Yeah.
And again, maybe that's a question more for law enforcement, but I'm wondering whether or not you're teaming up with law enforcement and what that looks like so that we're tackling it.
Right. No, I would love to prosecute these folks. Believe me, there's nothing more maddening to me than somebody stealing benefits from the people that need it the most. We are working with the local law enforcement, state and federal authorities. We are, like I've said, our focus primarily, we're not a law enforcement agency, so our focus has been on protecting the clients. But these are large-scale schemes. These are not, by the onesies. We're seeing it come in big waves, and go away. So we'll just continue to do that. We are hoping that there'll be some traction on some of these cases that we'll be able to prosecute. And in California, they have prosecuted some. And that, I think, will really help to serve as a deterrent. I mean, we don't even know if some of this organized scheme could be orchestrated within the country. Some of them could be outside of the country. So this is like I said, a nationwide issue, and the USDA is looking at it closely and investigating, and we'll provide any information. If you have any contacts in any areas of law enforcement, we'd be happy to work with you as well.
Thank you.
Yes, and we're going to finish up with Senator Cronin.
Commissioner, thank you for your testimony here today. In the department's 2022 annual report on the standard budgets of assistance for TAFDC, the department acknowledged that grants have lost value over the last 30 years. For example, the federal poverty line in 1989, we've gone up 129%, while cash assistance has gone up 32%. I'm just wondering if you believe that the grant amounts provided by the department are adequate to meet the purposes of the TAFDC program.
That's a great question. And for those of you who aren't familiar with the report, it also explains about the full package of benefits that clients receive. So, there's no expectation that a client would be able to meet all of their needs with the $700 as you quoted. So it's really, for us, a matter of trying to get the clients engaged in the employment and training and the upskilling so that they can, get a career ladder that pays a good wage and is not, leaving them stuck in that cycle where the cliff effect comes into play. That's
Do you
our
have data
focus.
on hand for how many people work, you qualify as success moving through that program?
Moving through our pathways to, I don't have data here. I can try to get that for you, but what I do know is that we have seen an increase since we redesigned the program in the number of clients that are getting jobs, leaving for earnings, and a decrease in the length of stay for clients by 7 months. So they've been able to, move off of assistance. But as far as, data on how many outcomes, I'd have to get back to you on that.
Okay, thank you, Commissioner.
Okay.
Great. Thank you, Commissioner Sheehan. We really appreciate you being here today and providing your testimony.
Thank you. Thank you all.
I'd like to invite Acting Commissioner Reardon from the Department of Youth Services.
Good afternoon, Chair Cronin, Chair Lenatra, and distinguished members of the Joint Committee on Ways and Means. My name is Cecily Reardon, and I am the Acting Commissioner for the Department of Youth Services. With me here today is our Deputy Commissioner for Administration and Finance, Matt Cole, and also in the audience we have our Chief of Staff, Tula Sabanda, and our Budget Director, Crystal Lanton. I am honored to appear before you today to speak about the Department's mission, priorities, and the fiscal year 2024 House 1 budget. This is both an exciting and a challenging time for the Department. We are, as you know, the Commonwealth's Juvenile Justice Agency. When I last appeared before the Joint Committee, DYS was in the beginning stages of launching a new strategic plan with a new mission, a new vision, and a set of core values that we hoped to embed in every aspect of our work. Since that time, we have enlisted staff from across all roles. We've enlisted our young people, and we've enlisted parents to help us work with our executive team to identify a series of strategic goals that embody our values and that we believe provide a framework to help us fulfill our mission and our vision. The strategic planning process identified tremendous opportunities for DYS to impact the lives and futures of the young people in our care and custody, as well as new ideas about how to best partner around preventing system involvement in the first place. It also highlighted the challenges we face as our workforce and our young people recover from the COVID-19 pandemic. Like other youth-serving agencies, we have needed to develop new strategies for recruiting and retaining qualified staff. We have also needed to respond to the pandemic's compounding impacts on a population of young people who already face significant obstacles. Governor Healey's proposed fiscal year 2024 House 1 budget of $182.6 million provides impactful support for our strategic plan investments. And consistent with our mission, it allows us to improve and expand preventative and rehabilitative services for our young people, as well as promote family engagement and community supports, and ensure a fair and equitable juvenile justice system for all. As you all know, DYS has seen a significant decline in its traditional census over the last 10 years. Much of this is attributable to our significant investments in preventative work with other child-serving agencies such as DCF, DMH, as well as DPH, and our juvenile court partners as well, including our latest partnership with the Office of the Child Advocate, where we have partnered to create new diversion learning labs, 5 of which in 5 counties across the state. This decline in census has really necessarily required DYS to right-size its continuum and invest in the services and the supports that this distilled population of young people need. We now serve a population of young people who are on average older. On our detained census, young people tend to be at least 16. And on our committed census, we are seeing young people on average at age 17.8, so very close to 18. Our young people have significant trauma histories and trauma reactive behaviors, and that requires significant staff responses. We also have young people who disproportionately hail from impoverished communities plagued by systemic racism. Our young people have diagnosed learning differences and are often years behind in school when they come to us. And especially now, our young people come to us with significant unmet behavioral health and substance use needs. Governor Healey's budget allows us to meet our young people where they are right now and provide the individualized treatment and supports that they need to not just return safely to our communities, but to thrive. Let me give you some highlights. So the governor's budget allows for us to make some quality of life investments in our residential programming that reflect youth voices I prefer to say, because it's not just one young person's voice that fits into this equation, and also translate, we believe, into safety in our programs and positive community connections. For example, the budget allows us to provide our young people with culturally responsive hygiene products sourced through local small businesses, creating potential employment pathways. The budget also supports our expansion of Wi-Fi capabilities in our facilities, which we've used to enhance family engagement opportunities, support virtual court hearings, and create other types of opportunities for virtual programming. The governor's budget also allows us to increase our investments in educational and career readiness supports like early college, our partnerships with local community colleges, and trade certificate programs. Our research has shown us, actually partnership with Boston University, we can't claim all responsibility for that, but what our research has shown us is that DYS-related educational and career readiness supports for committed young people, as well as for our youth engaged in voluntary services post-discharge, are key factors in preventing and protecting against recidivism. We've also learned that while we want every young person to see themselves as college material, that's not every young person's chosen path, nor should it be. And so what we've done, and we're very excited about this, and we're very excited about the support that the proposed budget will provide for this, is we really try to increase our vocational investments. We have a Skill Up initiative that a procurement actually that we made last year, and the governor's budget will support that and allow us to expand it. And things that we're doing through that procurement are things like repurposing spaces in our existing sites to support additional vocational opportunities. Like we converted an underutilized space in our metro region into a fully functional barbershop. And the budget also allows us to invest in an all-new girls' continuum. I think many of you have seen recent media coverage about how hard the pandemic has hit young women, and we are very well aware of that. And so we are using these opportunities to create an entire new girls' continuum that provides community-based gender-responsive services in each of our 5 regions. The budget also includes outside language, and that outside language enhances the preventative power of our voluntary services. It's our Youth Engaged in Services initiative, by allowing young people to request or resume voluntary services at any time post-discharge until they turn 22. Now, these critical investments for young people supported by our governor's budget necessarily also require us to make investments in our workforce. We cannot provide young people the programming they require without first ensuring that we have a workforce that is stable, feels supported, valued, and safe. To that end, the budget allows us to invest in updated and expanded training that addresses the complex needs of the young people we have today, including gender-responsive modalities, how to best support the unique needs of LGBTQ youth, as well as trafficked youth. The budget also allows us to invest in recruitment and retention strategies to ensure that we are hiring, developing, and promoting a workforce who reflect our young people and the communities we serve. We are engaging with existing staff to utilize their personal networks through the Commonwealth's referral bonuses. We're supporting new staff by expanding our pilot staff mentor program to all of our regions. We're also improving staff safety through a pilot of personal safety alarms to ensure we know immediately when a staff member needs assistance. The budget also importantly supports our internal work on race equity and inclusion, designed to engage our staff in exposing and eradicating implicit biases and educate them about the impacts of racial trauma on our young people, their families, their communities, and our workforce. These are just some highlights of the critical work that Governor Healey's proposed budget supports. Critical work that we believe will alter the trajectory of young people before they enter DYS. as well as support their safe and successful returns to their home communities. I look forward to working with this committee and the entire legislature to fulfill our core goals and our objectives. And I thank you for this opportunity and for your time. I'm happy to answer any questions you may have.
Sorry, I feel like I'm a broken record here today, but thank you, Commissioner Reardon. For most people that know my story, the men in my family were all either incarcerated at some point in time, or I lost a young brother in 2017 that really catalyzed me to run for office. And so this is an issue I care a lot about in terms of juvenile justice. I just want to share some facts with you about our system of juvenile justice, and then I have a question about data collection. Massachusetts is one of the worst rates of racial disparity for youth incarceration in the country. Despite more than a decade of reforms to reduce the pretrial detention of young people, while youth of color and all-encompassing of color make only 36% of the youth population in Massachusetts, they represent close to 70% of those in custodial arrest, and 77% and 75% who are detained or committed to the Department of DYS. Black youth in Massachusetts are 8.8 times to 10.1 times as likely as white youth to be detained and committed to DYS, respectively. And Latinx young people are 7 times to 8.9 times more likely than white youth to be detained and committed to DYS. For youth incarceration, a national comparison study found that Massachusetts has the 9th worst black-white disparity and the first, or number 1, in worst Latino-white disparity in the nation, and that's by the Sentencing Project. A couple years ago, when I was a representative, we had cases of 4 young people coming out of DYS facilities who were dead within 2 months in Boston's neighborhoods. And, you know, it boggled my mind on how we're supposed to rehab young people and keep them safe and ensure that they're not going to the adult carceral system. But it seems like there's a direct correlation between young people in DYS facilities that are either returning back to the DYS facilities if they're under the age of 18, going into the adult 15 prisons that we have in the Commonwealth, or sadly, some of them not even making it out within 90 days of the DYS system. And because I represent a community that's largely of color, this is something that has been on my heart and mind as we begin to fix the system. Consistently, the legislature, advocates, and family partners have worked to access demographical information without success. You talked about this strategic plan, so I really would love to get your sense of what has the system done differently to collect the data. We often can't change or improve things we don't measure. And it's incredibly important as as we give more money to systems that we actually want to see these disparities actually reduce and then be eliminated, and that we're making strides to improve the system. To hear that black youth are 8 to 10 times more likely, or that we're the worst in the nation around Latino white disparities in the DYS system is disheartening. And I want to make sure that we're improving the system before we're adding more funds to a system that may be broken.
Thank you, Senator Miranda. I share your concerns very deeply. Prior to coming to DYS, I spent 17 years as a public defender representing young people in Roxbury, Dorchester, and all of the communities in Boston. Part of the reason I am at DYS is that DYS was the only agency really working to try to reform the system. At that time, DYS had brought, actually it's now 15 years on, that the Department of Youth Services brought in the Annie E. Casey Foundation Juvenile Detention Alternative Initiative. That is a national alternative, it's a national initiative that's in most states. That is specifically designed to reduce the use of detention, and the hope in the Casey Foundation model is that by reducing the use of detention for young people who don't need to be in detention, that you will thereby reduce disparities. Like every other state in the nation, however, Massachusetts has seen that while we have had, I think since 2015, we've had a 47% decline in our census, that we have not seen a decrease in disparities. We track these numbers daily. And we provide these numbers in our annual report. We provide these numbers. We're actually working with the Executive Office of Public Safety and, not Public Safety and Security, I'm sorry, the Executive Office of Technology, EOTS, to pilot a new JDAI dashboard so that we'll have data even more readily accessible. We partner with the Office of the Child Advocate on their Juvenile Justice Policy and Data Board and the report that they publish every year. And so we actually, and we respond to hundreds of public record requests every year. We are actually, most entities in Massachusetts, when they are using juvenile justice data, they're getting it from us. So that is something we actually take some pride in, is that we do collect a significant amount of data. Because what we realized probably not soon enough, is that, for many years the mantra was, we don't control our front door. And so we thought, okay, well, we just accept the young people who come to us, and if there's racial and ethnic disparities upstream, we'll do our best not to exacerbate them. We'll try to mitigate them. We'll try to make a difference. But what we came to realize is that that is not enough, and that there is this preventative language in our statutory mandate that requires us to step up. And that's what we started with JDAI, and now with our partnership with the Office of the Child Advocate around pretrial diversion, we're really hoping that that can also make a huge difference in that pipeline. Because we feel those disparities very, very hard. We just take it to heart very strongly, and it's something that is also part of our internal racial and race equity work. What we've tried to do over the last 6 or 7 years is educate all of our managers, educate all of our decision makers about the impacts of systemic racism, about racial trauma, about implicit biases, and how all of that impacts the decisions that we make as an agency, whether it be about where a young person is placed, how long a young person spends in treatment, when to return them from the community, and to really make sure that we are looking at each decision point through a race equity lens. We're also trying to do that with our staff in terms of the hiring decisions we make, the firing decisions we make, decisions about discipline, all of that. We have made a huge commitment and a huge investment. Actually, that's one of the additional things that this budget allows us to do, is to continue our relationship with some of our contracted providers who are providing us the technical assistance for those trainings. We have our own in-house race equity training that every single employee attends, that we had actually our entire workforce attend, and now it's part of our basic training, so every new employee also attends it. We've used that to also create spaces for our staff to have difficult conversations so that they're prepared to have the difficult conversations necessary with young people about current events. So we take every incident that happens in our communities to our young people extremely seriously. We do investigations into what has happened if a young person does not successfully return to the community. And we also retooled how we look at when we bring a young person in from the community, because we know that there's only so much we can do in residential treatment for a young person. We have to give them the tools so that when they come back to their communities, they can apply what we've helped them learn to their own situation. We can't just simply put them in a sort of hermetically sealed space and hope that if we toss them back into everything else that was going on for them, that they'll somehow swim. We just can't do that. So one of the things that we really are focused on is, when our young people are in the community, is building a very solid team around them. We have a caseworker that starts from the moment of commitment with that young person. We have family engagement specialists. We have job support specialists. We have youth development specialists, all who form a team around a young person in the community. And the goal really is for our young people to be in the community where we can then work with them to fine-tune a plan that ensures their best success, where we can actually pull them back in if we need to, because things have not gone quite right, in a safe and productive way, so that when they finally come to a point where they're readying for discharge, that they are the best equipped they possibly can. We also, in 2014, or it might have been 2012, we took a very hard look at our voluntary services opportunity. That's been on the books since 1973. But it wasn't until 2012, 2013 that we started offering it to every single young person with an aggressive sort of full court press to make sure every young person knew that it was available. And what we see now is that 68.9% of young people leaving our custody request and accept voluntary services. And the average length of stay in voluntary services has ticked up to about 16 months. And we're finding that participation in voluntary services has had a significant protective impact on recidivism. We find that it can be as much as a 8% decrease in recidivism if a young person participates in our youth engagement services. It's really an initiative because we talk about programs as sites, but so it's an initiative. And those services range from educational support, employment support, housing support, clinical support, and they all include everyone has a case manager as well. The outside language, just so it's clear, that allows young people, when we first expanded it in 2016, I believe, to include 22-year-olds up to the age of 22. Previously, it ended at 21. So our youthful offenders would leave our custody and not have any opportunity for voluntary services. So we expanded the legislation to go to age 22, consistent with other agencies, so that our youthful offenders would also have that opportunity. When we did that, we initially included a 90-day sort of period of time where someone who rejected services could come back. And we thought that would allow us to sort of monitor how many young people were coming back, what we could really afford to do. And what we found was that was really contrary to positive youth development. Our young people need to be able to change their minds as adolescents and even older adolescents do. And so now we've removed that 90-day cap so that young people can come back anytime until the age of 22. And those are some of the things that we're trying to address, the really critical issues that you raise. And it's something we're investing in, looking at national best models, everything we possibly can to try to make it most likely that a young person will be successful. We don't always win. And those situations break our heart. Actually, we've now brought on a series of trauma responsive specialists to work with our staff and also our young people to influence how we care for our young people, to deal with just those situations.
Thank you so much. And the last two questions I'll leave for another day. I can email you, and maybe we can go visit the Harvard Street location.
Absolutely.
In my district. I'm really excited about going to see there. This is for the ANF. Sorry, I forgot your name.
Matthew Cole.
Hi, Matthew. I saw in the budget that you requested, or there's a line item around the Second Chance Act, and it was for $25,000, and that just felt really low. For me, I don't know how many young people you have in your statewide DYS system, and so I'd love to hear more about that maybe another time. And then you spoke a lot about women and girls, and that is something we have seen an alarming rise also in Boston. A sad statistic is out of the 50 to 70 homicides we've had in Boston over the last few years, almost like 10 to 20% have been girls or trans young people. And that began to really spike up my interest on what is happening to our girls. Are they in facilities? Are they being overcriminalized? Is there something happening in our gang culture in the city, or just even street culture, that is impacting girls differently? But I didn't see a specific line item or request on how you're serving girls, and so I didn't know whether you're going to come to us and say, hey, we see this alarming trend and we want to increase that budget line item to be able to better serve girls and women.
So actually, the budget itself includes what we've factored in to be about $1.9 million. That's going to specifically support the restructuring of our girls' continuum. And what we found is that while young women comprise approximately 15% of our entire census, and LGBTQ plus youth about 6%, those populations absolutely require specialized attention. And we actually, we've spent now the better part of a year and a half with our internal and external experts building out a model for a new girls continuum, and we hope to issue a request for responses within the next 2 months to really try to launch something in the fall. And what we're actually doing, so we currently have about a 54% utilization rate in our current girls programs, but they skew towards hardware secure locations. So what we're trying to do is completely revamp that. And so we're seeing a net decrease in 18 beds, and the majority of those are in hardware secure settings. And so what we're envisioning is 5 staff secure locations in communities around the state, so that we have one in each of our regions, so that young women can be closer to home. closer to their communities, that they can have enhanced family engagement opportunities. Because what we've seen previously is we come up with great ideas for a program in the middle of a different part of the state than, say, from where a young woman from my neighborhood in Boston is from. And so that young woman would say, oh, this is a great program, but I don't want to be in this community. Don't you have something in my community? And we found that it makes such a difference if we can allow young people to maintain as many community connections as possible, especially for our girls because of their relational needs and how that factors into the treatment they need. So what that $1.9 million does is it allows that new system of localized support. It also allows us to enhance our gender-responsive training. And it also allows for a host of new positions to sort of aid, that will aid transition for young women who are detained back to their communities, because the majority of young people who are detained in our programs are never committed to our custody. They spend some amount of time in detention, but then some other plan is worked out, or their case is dismissed, or many other things happen. But what this really this allows us to do is to have a much more warm handoff, I guess would be the way to look at it, for young women who are returning back to the community. We're also hoping to pilot that in some of our boys' locations, but we're going to see how it goes with the girls first. But that's some of what that $1.9 million will do. And so we're looking at that RFR now, and we are hopeful that amount of money that we've allocated will allow us to make that significant investment successfully.
Thank you. Sorry, I had so many questions.
Thank you, Senator. We're going to try to attempt to go to Zoom. I'd like to recognize Representative Doherty for a question.
Oh, thank you very much to the chairs. I appreciate that. And the presentation and the caring that's obvious in the presentation about our youth who are incarcerated for or in transition for one reason or another is really important. And I hope that caring goes down, trickles down to the staff so that they are expressing the same thing to our youth. I visited the DYS facility here in Taunton, and I was impressed by the young people who were there. We had an opportunity to interact with the young people who were there. They were particularly proud of their success in the early college high school program. It was very interesting to me. What they wanted to do very much when I stepped into their academic classes was to show me where they were in their studies with early college high school and how much they had accomplished in that regard. I think that program is so important, so I'm hoping that continues. I had a concern at the time, and I would ask the question about the wait that young people have for court hearings. There was a young man who was there for many years and had not had his court hearing scheduled at all. So I would ask that question. I asked the same question about our adult population as well. How long do people wait to have their court hearings? And lastly, there is decidedly, and you mentioned it earlier, an uptick in the number of youth who are having behavioral and emotional issues in our high schools. And so the question is about what the interface is between the Department of Youth Services and our high schools in order to kind of mitigate the numbers of young people who are going into the DYS services, or at least provide them the kind of service that they need as young people who are having some great difficulties in this social environment. Thank you very much for your hard work. I appreciate it.
Thank you very much for your questions. I'll answer them the best I can. I can tell you that we are very invested in early college, and we see it as a real opportunity for our young people. So that absolutely is going to continue. And actually, the Wi-Fi investment will help us with some of our facilities to increase the number of remote classes that we're able to bring to the table directly from universities. We've had universities express significant interest in partnering with us around that, including Brandeis University. So that's something that we are absolutely committed to continuing. In terms of what we see around the behavioral issues, the behavioral health issues that you're speaking about in high school settings, we do a lot of work with our young people. Education is a huge priority for us, but young people who come to DYS remain attached to their home high schools. We do not operate a school per se, we operate classrooms. So young people, we provide general education to every young person in our programs. The Department of Elementary and Secondary Education is responsible for special education in our programs, but we try to maintain connections with a youth's home school. So within the first week, we are checking at least 2 times to see what a young person's educational needs are and collaborating with their school to get information about what classes they were taking, what their individualized education plan was, and so that we can make sure that we're implementing that as soon as possible. And we also work with families and young people to make sure that we have a transcript that they can take with them back to their home schools so that they're best equipped to get credit for the educational work they do in our programs. And also some of our collaborative work, especially with the Mass Municipal Police Training Committee. We've talked with them about their work around school resource officers and the training and parameters that they're setting in place. So we're part of those committees and at those tables and lending our expertise to those conversations, as well as I think our diversion work is probably a critical piece of that with the Office of the Child Advocate. So right now, what we're sponsoring is the opportunity for judicial diversion. It also includes judicial diversion, diversion by police officers, diversion at the district attorney level. Essentially, any of the entities that are allowed by statute to divert, we are serving them with our diversion pilot learning labs. And so we're also connecting in those contexts with school police officers to see if that's an appropriate referral. I hope that answers your question.
Yes, thank you very much. I appreciate that.
You're welcome.
Any other questions from the committee? Commissioner, thank you very much for your testimony today. We appreciate it.
Very welcome.
Thank you. I'd like to invite Commissioner Tony Wolf from the Massachusetts Rehabilitation Commission.
I'd like to introduce Mo Vasquez, who is our CFO and incredible strategic partner, who nags me almost every day. So thank you. It's really an honor to be in front of you all today. As indicated, I'm Tony Wolf. I'm the Commissioner of the Massachusetts Rehabilitation Commission, and I'm here to really speak to the issues of our mission, our priorities, and Governor Healy's House 1 fiscal year 24 budget. For many decades, people with disabilities have challenged mainstream culture to recognize that disability as an important aspect of their lives, not the whole of their lives. This movement has inspired the Massachusetts Rehabilitation Commission since its inception in 1956. It has shaped our values and our perspectives, and we have strived to break down the societal barriers and expand what's possible for people with disabilities across the Commonwealth. Today, MRC continues to push boundaries, going beyond service delivery to create innovative partnerships to meet the evolving needs, interests, and aspirations of individuals with disabilities and their families. Governor Healy's proposed budget of $88.9 million will allow MRC to continue to recruit, retain, and train our dedicated workforce, fund effective services, and make strategic investments in service models and expand what's possible in the lives of individuals with disabilities. We are in the business, if you haven't noticed, of possibility. Our services focus on training and employment, community living, and disability determination for federal benefit programs. The budget will increase funding for the supports that address the needs of individuals with disabilities, including additions to independent living assistance, individuals with traumatic brain injuries, and assisting individuals with physical disabilities transitioning out of high school with their supported living needs through our Turning 22 program. In addition, the increased budget of $3.9 million in our vocational rehabilitation services, training and employment services will enable us to enhance service delivery by ensuring our workforce have the time and resources needed to focus on supporting job seekers with disabilities, leading to increased work placements. MRC has served 19,000 plus job seekers through our vocational rehabilitation division, assisted 15,000 individuals through our community services division, and through our disability determination services has deemed eligible 64,000 people. These individuals who were placed have earned salaries that collectively total $75.7 million in their first year of employment. The estimated public benefits savings from these individuals in the workforce in Massachusetts has resulted in $22.7 million. So I guess I'm suggesting it's worth the investment. I now just want to take a few moments to highlight the initiatives this particular year that we've accomplished. These days, we are all spending on time, as I'm looking at our remote colleagues online. We want to make it as easy as possible for people to learn about what we are about and access our services from home. We now have something called MRC Connect, which is our virtual gateway, our front door. It has allowed an individual to access all our services once for eligibility across the Commonwealth. It has allowed people to call and actually talk to a human being to get assistance and understand the services that MRC provides, and, if necessary, assist them in applying for the online application. We know this has sped up access to services, increased retention of their interest within the agency, and I believe provided a superior customer service, putting the customer at the center. Last year, also, we're really excited about launching another innovative program called Next Gen Careers, and in an initiative to help young adults ages 18 to 30 explore the world of work. As we call Next Geners, enrolled in this program are paired with a team of mentors, counselors, benefit advisors, and employment specialists to help them navigate their career path. This has been accomplished through a grant that we have received from the Federal Administration, Rehab Services Administration, of $17.4 million. What we're excited about for Next Gen was that it was co-developed and designed with young adults. This program design is intentionally grounded in the belief that smaller caseload size is necessary to really enhance job placement, and it is particularly focusing on individuals from underserved communities, and we're very proud of that. We know collaboration works. We have partnered with our sister agencies, job seekers, to find solutions that have real impact for people's lives. Our goal is to strengthen our relationships. And as Commissioner DTA mentioned, we have this program together called Empowering to Employ, an initiative that we're really proud of together with the Department of Transitional Assistance. And we also have a partnership with the Department of Mental Health with a employment partnership that focuses on individuals living within the adult community clinical services arm. Empowering to Employ maximizes opportunities, as said, for individuals receiving transitional aid to families with dependent children. It is a joint funded model of engagement and co-case management between DTA and MRC, and it has really allowed sustainable, important employment for individuals and their families. MRC is interested in expanding our Empower to Employ program to cover all our MRC DTA co-location sites. Currently, we have 5 MRC DTA sites together, and we would like to expand this to now have the remaining 8 MRC DTA sites and being able to expand their staffing services. Through our ACC partnership with the Department of Mental Health, we were very excited that this has been a very successful program and is now part of our base of services within Mass Rehab. Our community program has also played an intricate role in providing supports for individuals' pathways to becoming self-sufficient. We have provided services through our waiver programs, services like transitional housing searches, transitional assistance, which is funding support necessary for furniture acquisition, getting people comfortable in their homes, all right, and any other household necessities. We are also really excited through the waiver program that we've been able to support 888 individuals from the nursing homes into their communities. More than 488 individuals have received home modifications, allowing them to transition successfully in their homes, and 11 individuals have been able to receive vehicle modifications. And these vehicle modifications are incredibly important to individuals who now want to be independent in the community and actually find employment. We also have to say that we are fortunate to have received American Rescue Plan Act dollars, and we have a total number of $19 million that we're expected to be actually expended by March 2025, and there's an array of services that we are providing under this program. Let me just say, I think what's really critical is to make sure that the people we serve are at the table, that the people we serve are part of our decision-making process. If we want to build new services, we need to make sure they're there to inform us what's really important to them. So we're really excited that this year, as one of our initiatives, we have contracted with 10 disability inclusion leaders and 10 family partners. Those are individuals with families, either moms or dads or grandparents, who really have that perspective and want to be sure that we hear what their perspective is in caregiving roles. And in August, we had our first, finally, in-person conference where we pulled together 300 individuals. And just like today, it's nice to see everyone's face. We were so excited to have 300 people come together and really feel the energy and really learn from each other, to be able to speed professional networking, to do deaf networking services, to have a lived experience panel to really talk about the services and how they could recruit others to understand the services MRC provides, and really have what I call innovative conversations. So as you are hearing, MRC is changing. And not that our vision necessarily or our core is changing, but the way we talk about ourselves are changing. And with that, we also want to be able to, at this point in time, change the name of our organization. And we have been very excited to be able to talk to our disability communities to really vet some ideas, and have conducted a number of research activities to really be able to look at how can we transform the name of the agency to be current for today, to be able to be current to the next individual that wants to walk in our door. So I'm not yet ready to be able to share that name, but I will really be eager to work with each one of you to help us with that. So let me just state that our House 1 budget of $88.9 million submitted by the Governor Healy supports continued progress for MRC and allows the agency to strategically utilize funds to better meet the needs of individuals with disabilities. We are grateful to Governor Healy, Secretary Walsh, and all of you and the members of the legislation. You have been incredibly supportive to MRC and incredibly supportive to the people with disabilities. And today, I just really want to thank you all, and grateful to any questions you may have.
Thank you, Commissioner Wolf. Any questions from the committee? Yes, Representative.
Thank you. Thank you, Commissioner. Amazing work going on. I'm kind of sorry that I have to bring this up, but we all learn by sharing information. So I had one constituent. It ultimately wound up okay, living independently, couldn't get job help. What is the delta between what you're able to provide and your resources?
It's a great question, which is why we're really excited about the 3.8 increase in our services, particularly with employment and training. Our caseloads are too high. And so we don't have the availability to really spend the time to truly engage people. And that's part of the work that has to happen, is engage with individuals. This will be the first time that we have asked at MRC for state dollars to really look at caseload size. And so I really am eager to have you support the governor's budget. I also want to say that in order for us to really engage, we also have to go where people are. And that's equally important. So it has to have counselors have to have the time to go where consumers are, rather than always thinking that someone's coming to us. So it's really shifting the paradigm, it's shifting the model, all right, which is why these dollars for vocational rehabilitation are so essential.
Thank you. I appreciate the candor. I'll probably be following up.
We'd be
Thank you,
happy
Madam
to.
Chair.
Thank you. Any other questions? Not seeing any texts. I want to thank you so much for joining us today and for your testimony.
Thank you very much.
Oh, geez. 1 second. I'm sorry. I believe Carol Doherty has a question. Oh. She does. I'm sorry.
Oh,
Representative Doherty.
Thank you, Madam Chair. You must have heard me say, oh, to the screen. Thank you very much. Yes, I do have a question. Some weeks ago, there was a lengthy editorial in the Boston Globe, written, 2 editorials actually, written by parents who are parents of adult children with disabilities. And they raised the question about the legislation that was adopted in 2014 called Real Lives, with a grave concern about the fact that that Real Lives legislation had not been implemented at all since that time. Just prior to that, as I understand it, and I wasn't here in 2014, but there was a hearing. Our regulations finally were promulgated. There was a hearing, and I was told that there were about 200 people who attended the hearing, and some 50 or 60 people attended the hearing, and no one of them felt that the regulations were compatible with the intent of the Real Lives legislation. I don't know if this is in your bailiwick or if you are familiar with it or even if it's on your desktop, but I think that I would like to have an update, if you have one, at some point in time, if not now, about the status of those regulations and the full implementation of that legislation.
I'd be happy to get back with you. I actually do not know that much about what happened in 214. But eager to kind of learn with you and really share. You know, we have been looking at our regulations across MRC to really make sure that services are accessible as much as possible. So I'd be delighted to talk to you.
Yeah, just a footnote on that, the legislation has to do with self-determination of these adults as they move through their lives. And I recently was invited to a birthday party of a young man who turned 30, who was not expected to turn more than 5 years old. And he is a young man that has managed, with a lot of help from his family and with the state and federal resources that have become available in programs, to have a self-determined life. And I think that we need to take a look at why the regulations that have been promulgated don't seem to be compatible with the intent of the legislation. So I would really enjoy talking with you further, if you are the person to discuss this with, about what that future looks like. So thank you so much. I appreciate it.
Thank you very much.
Okay, last chance. Seeing no other questions. Thank you so much again.
Thank you very much.
And just a note for all members of the committee, we're going to power through our testimony, so please feel free to get up, and there's some light finger food and sandwiches outside, and we'd invite all guests who are testifying to help yourself to refreshments as well. At this point, we'd like to call Commissioner Opie Satanwa from the Massachusetts Commission for the Deaf and Hard of Hearing to testify. Thank you, Commissioner, for being with us today.
Good afternoon, Chair Cronin, Chair Lenatra, and members of the Joint Committee on Ways and Means. My name is Dr. Opioloa Sotanwa, and I am the Commissioner of the Massachusetts Commission for the Deaf and Hard of Hearing, MCDHH. I appreciate the opportunity to join you today to discuss the important work of our agency and how Governor Healey's fiscal year 24 investments will support our continued efforts to serve the approximately 1,400,000 individuals who are deaf or hard of hearing in the Commonwealth of Massachusetts. Most significantly, MCDHH is responsible for ensuring that deaf and hard of hearing individuals in the Commonwealth can access quality and timely communication. MCDHH provides American Sign Language, or ASL, English interpretation, and communication access real-time transcription, or CART, referral services, including 24/7 standby referral for press conferences, referral for court and legal proceedings, and referral for emergencies, as well as ASL English interpreter training, mentorship, and quality assurance, communication access training, and technical assistance. Additionally, MCDHH provides critical case management and independent living services for deaf and hard of hearing adults and children in the community. As leading experts in accessibility and services for the deaf and hard of hearing, MCDHH partners with sister agencies and community entities to increase accessibility and improve the quality of services existing and new throughout the Commonwealth. This includes working directly with agencies such as DCF and DMH to ensure accessibility is integrated into their service models and to support deaf and hard of hearing employees working for the Commonwealth in these critical tasks. Our dedicated and passionate staff provide the Commonwealth with the resources it needs to serve deaf, hard of hearing, and late deafened individuals in an extensive range of human service, healthcare, safety, legal, education, and economic settings. With the support of the Healey-Driscoll administration, MCDHH will continue to ensure that deaf and hard of hearing individuals living and working in the Commonwealth enjoy access and opportunity to all of the public services, opportunities, and benefits that Massachusetts has to offer. The proposed operating budget for MCDHH for FY24 is $9.9 million. In line item 4125-0100. The budget recommendation is $1.4 million, or 16% above MCDHH's FY23 General Appropriations Act. The FY24 budget includes critical funding increases over FY23 that will support MCDHH to expand and improve the work we do for our constituents. In regards to increased support for our Communication Access Services Division, increased funding for legal ASL interpretation and training will allow MCDHH to add critical capacity to fill requests for communication access in courtrooms and other legal settings. Legal events that were postponed during the pandemic have now been returned to the docket, and deaf individuals will be returning to jury service. These increased communication access needs have stressed an already fledgling workforce. Because of the limited pool of qualified legal interpreters, court events must be rescheduled or scheduled around interpreter availability, which slows down the resolution of cases. MCDHH has identified a subset of interpreters who will receive additional legal training and courtroom experience necessary to become fully qualified. With these focused trainings and retention efforts, MCDHH hopes to double the number of qualified legal interpreters within the Commonwealth. The increase in annualized funds will not only address the workforce crisis currently experienced by MCDHH, but it will also address the critical needs of the trial courts, the jury commission, and the Department of Children and Families. Court proceedings that were postponed during the pandemic have now been returned to the docket. Deaf individuals will be returning to jury service, and the numbers of families involved with DCF remain at a critical high, while the workforce has decreased. MCDHH's focus on recruitment, training, and retention will add qualified legal ASL interpreters and deaf interpreters from surrounding states to our referral list to address these significant workforce issues. MCDHH plans to increase our staff capacity by at least 2 FTEs, as well as recruiting, training, qualifying, and retaining at least 15 or more local freelance interpreters willing to work regularly on-site in court and legal settings. With annualized funding, MCDHH is developing specialized trainings for interpreters to increase and diversify the pool of qualified providers who are able to provide communication access across a variety of unique settings, including medical, behavioral health, substance use disorder recovery, and in particular, interactions between the Department of Children and Families, deaf caregivers, and other community-based legal settings. Through offering these targeted trainings, MCDHH will enhance our capacity to provide linguistically and culturally competent services and diversify our pool of communication access providers in these settings with the goal of doubling the current pools of interpreters to meet the critical communication access needs of the deaf and hard of hearing people we serve. Annualized funding for the after-hours emergency communication program enables deaf and hard of hearing individuals to access interpretation outside of our regular hours.
Yeah, critical.
Since expanding our services to include after-hours emergency services in FY23, we have seen a 52% increase in the number of emergency requests. From April 2022, the first month that the pilot was implemented, through February of 2023, the number of emergency requests went from 4 per month to over 30 per month. And these numbers are continuing to increase. This funding will support an after-hours emergency coordinator and add incentives for after-hours communication access providers who are willing to accept emergency on-call shifts. Through this expansion of the program, MCDHH will be able to provide emergency referral services sufficient to meet the rapid growth in demand, evident in the 52% increase in requests since this pilot began. Over 1 million individuals in the Commonwealth rely on assistive technology, such as hearing aids. Yet many adults from economically disadvantaged communities cannot obtain and utilize these assistive technology devices. MCDHH will use available funding to assess issues impacting access to affordable hearing aids and develop a program model to increase access for under-resourced individuals. Through our strong partnerships with agencies within EOHHS, MCDHH is engaged in ongoing efforts to increase the number of human service employees who are fluent in ASL and culturally competent to provide direct services to deaf and hard of hearing individuals. In our cross-agency work, MCDHH seeks to increase awareness of the diverse needs of our constituents, including the hiring of deaf and ASL fluent service providers and interpreters who reflect the diversity within the deaf and hard of hearing community. MCDHH seeks to model these principles within our own agency and to provide education and resources to agencies and departments seeking to grow their own workforces. Expansion of case management and social services. Increased funding in the FY24 budget allows MCDHH to hire an additional children's specialist to serve our deaf and hard of hearing children from birth to age 22 and their families in a better way. Children's specialists work with children, families, and schools to help make informed decisions and provide tools to advocate for the needs of deaf and hard of hearing children, especially around issues of early language access. And that's early access to language, either signed or spoken. Studies have shown that language deprivation has a severe and lifelong lasting negative impact on deaf and hard of hearing children. Through increasing our number of children's specialists, MCDHH will be better able to structure our program to meet shifting geographical needs and balance caseloads to ensure families and children receive high-quality, responsive supports. The children's specialists provide a lot of technical support around individual education programs and 504 plans related to the Americans with Disability Act, both with the parents to understand what it means and also with schools to help them understand the unique needs of deaf and hard of hearing children. MCDHH has noticed an increase in referrals from all over the Commonwealth. Many issues are related to the pandemic. Inability to access the curriculum while remote learning was occurring. Missed school therapies and other services. Late diagnosis due to not being able to get tested. Little or no intervention services, etc. The Boston area has historically been underserved because of language and immigration concerns. Parents are afraid to ask for our help. We need a dedicated children's specialist in this area to do more outreach to families to ensure that deaf and hard of hearing children are not missing vital services and that they have access to language from a very early age. Communication Access Training and Technology Services. MCDHH continues to build capacity to provide technical assistance and communication access support to EOHHS agencies, creating vlogs. Vlogs are recorded visual content that is made available online. They are essential in ensuring that the deaf and hard of hearing community has full access to Commonwealth trainings, announcements, and other critical information. With the increased funding, MCDHH will hire additional staff to support the Communication Access Training and Technology Services Department in providing these services. MCDHH will upgrade our website to vlog hosting capability. This will bring us in line with what we have long envisioned to be culturally and linguistically accessible website content and provide a model for other public sector and private agencies to increase accessibility. In collaboration with various law enforcement entities in the Commonwealth, MCDHH is creating increased training opportunities for law enforcement on skillfully navigating with deaf and hard of hearing individuals how to maintain safety, reduce negative interactions, and increase the accessibility of emergency services. Deaf and hard of hearing independent living services, or DILS. FY24 budget proposed for DILS is $2.7 million, which is an increase of 8.4% over the FY23 budget per Chapter 257 rate review. This funding supports the essential work of the DILS centers, where deaf and hard of hearing individuals receive assistance with advocacy, communication access, health preservation, life skills, personal safety, and economic well-being. Through the 8 DILS programs statewide, individuals can access one-on-one support, peer mentoring, and assistance in the community, as well as attending various community-based education events, outreach activities, and social events. Recently, community members are accessing new programs that include free ASL classes and are receiving additional support around housing, advocacy, immigration, and benefit planning in response to changes impacted by the end of the federal public health emergency. EHS communication access funding, centralized billing. Included in this budget is a chargeback account 4125-0124, ceiling set at $6 million per fiscal year. This is to centralize contracted ASL and CART interpretation services billing at HHS agencies to facilitate on-time payments for interpreters and expanding services. Since we have piloted this model in FY23, we have been able to improve timely payment for communication access providers, making such providers much more available to take assignments at EHS agencies upon request. In closing, We have adapted our service delivery model, and we will continue to offer communication access solutions across various platforms according to the needs of our workforce and constituents, being cognizant that we encompass a diverse and highly individual constituency. We are mindful that online access is a privilege and that many community members do not have reliable internet access, nor laptops or smartphones, nor do deaf or hard of hearing and late deafened individuals currently have access to the same quantity and quality of education materials online as exist for hearing persons. As a result, MCDHH is emphasizing not only accessibility, but usability to an increasingly communicatively diverse audience across software and hardware platforms, from traditional hearing aids to lower-cost personal sound amplification products, as well as advocating for environmental notification products that help people stay safe in their homes and communities. We have responded to an increased demand for American Sign Language interpreting and human-powered captioning, or CART, services by establishing effective remote protocols and guidance, and advocating for increased access to platforms that did not initially consider the needs of our constituency. In doing so, we have ensured that we are all well on the way to meeting the increased demand, utilizing state-of-the-art technology and continually evolving guidance. The FY24 House 1 budget will support our efforts to consistently and proactively provide these vitally important services and to strengthen our community partnerships. We continue to make Massachusetts synonymous with leadership in the areas of communication access, integration of accessible technology, training our diverse communities so that they can compete on equal footing, and above all, a commitment to recognizing that each of us has a part that we can play in the foundations of an equitable society. I would like to thank Governor Healy and Lieutenant Governor Driscoll, as well as Secretary Walsh, for their incredible support of the Massachusetts Commission for the Deaf and Hard of Hearing. I ask that you support the governor's proposed budget that will allow us to continue to address the societal barriers deaf and hard of hearing individuals face every day. Thank you, and I am happy to take any questions you may have.
Commissioner, thank you so much for your leadership and your testimony here today. I want to talk a little bit about the after-hours emergency services program that you mentioned in your testimony. This is a new proposal in H1 for approximately $350,000. Could you describe a little bit about the vision for that program? Where will interpreters be located? Will they be available to deploy across the state or centered in Boston? And what is the hope for or expected response time for an interpreter to an emergency?
Thank you for your question. When I became commissioner 2 years ago, one important area that I first noticed of need was that our referral team closed and our staff interpreters were not available to be deployed. such that individuals could not access certain services. If they were having an emergency and they had to go to the ER, or if they were stopped by the police, they could not access services. So we have reinvented our after-hours emergency program such that we have interpreters on standby. We have a coordinator who works with our team. Individuals who are willing to be on the emergency list are on call, and they are paid a small stipend for being on standby for emergencies. If an emergency does occur, they are deployed. And we have interpreters in areas across the Commonwealth who are on this list. And we have had situations where there have been crises in the state of Massachusetts and there were not interpreters available. And we see crises happening nationally at this time, not just here in the Commonwealth. And, having lived through a pandemic and seen so many shifts in the needs of the community and technology, we have a lot of interpreters who are preferring to work from home remotely now, so it's harder for us to cover all of these emergency situations. So we are planning to address these issues by increasing our pipeline through our workforce development program. Most recently, we had a group of subject matter expert consultants who came to work with us and consult with us in how we could develop a 10-year action plan. And these subject matter experts are members of historically marginalized communities that we wanted to make sure we were including members of various communities of color in this process as we redesign these services. And also ensuring that our interpreter workforce reflects that community. And in Governor Healy's plan with Mass Reconnect, it's a program where if a person is over the age of 25 years of age, they can go to a community college free of charge. And we at the Commission for the Deaf and Hard of Hearing strongly believe that this will increase people's motivation to consider interpreting as a potential profession, and they can get training as an interpreter at a community college. So this could be life-changing for them and for our community. We're very excited about that.
Thank you. Any other questions from the committee? Senator Goby.
Excuse me. Thank you. I just had a question when you were speaking, Commissioner, when you mentioned about the dedicated specialist, and I believe you mentioned to have one dedicated specialist. And I'm just wondering, is that included in the funding? And from what you said that specialist would do, it sounded like we could use a lot more than one. So I didn't know if you would expound on that a bit. Thank you.
Absolutely. Thank you for asking. The after-hours emergency program is currently in a pilot phase. We have hired a contractor to assist with the management and operation of this program. And in FY24 budget, we are hoping to make that position permanent, the specialized coordinator.
Okay, just to follow up, if you don't mind, Mr. Chairman. So the funding is included in the FY24, or it is not, for that one position?
It is included.
Thank you.
Any other questions from the committee? All right, seeing and hearing none. Thank you so much, Commissioner, for being with us today in your testimony. Thank you.
Thank you.
Thank you. At this time, I'd like to invite Deputy Commissioner John Oliveira from the Massachusetts Commission for the Blind. Thank you, Deputy Commissioner. Welcome.
Good afternoon. Chair Cronin, Chair Lenatra, and distinguished members of the Joint Committee on Ways and Means. I'm John Oliveira, Deputy Commissioner of the Massachusetts Commission for the Blind. Thank you for the opportunity to provide testimony Governor Healy's fiscal year 2024 House 1 budget. The governor's budget represents the important and highly specialized programs and services provided by our team at MCB. MCB serves approximately more than 30,000 individuals in Massachusetts who are legally blind or deafblind. Our mission is to provide our consumers with access to employment opportunities and social and rehabilitation services with a goal to increase their independent living and self-determination. Governor Healy's FY24 House 1 budget for MCB is funded at $27.1 million, which is $2 million or 7% decrease from the FY23 GAA. MCB is pleased to report that all Chapter 257 rate services are fully funded. The Deafblind Extended Support Program, or as you know it, the Turning 22 program, is our largest appropriation, has received a small increase of $15,000, which we expect that projected chargeback costs will consume this increase. The Administration and Program Operations Appropriation 4110-001 has received an increase of $21,000, which is expected to be used to offset the increases in rent in our Boston and Springfield office. The $2 million decrease in the governor's FY24 H1 budget is largely attributed to removal of earmarks. The community services line item 4110-1000 contained a $1 million earmark, while the Massachusetts Audio and Information Network line item 4110-1010 contained a $1.1 million line item. I appreciate the opportunity to speak in favor of the programs and services that each of these appropriations provide to our consumers. MCB has principal programs and that support our mission. The social rehabilitation services that we provide promote the support and independent living of consumers in a community setting. The vocational rehabilitation services we provide prepare and support consumers while they are attempting to engage in competitive integrated employment or supported employment. The Turning 22 appropriation provides residential care, case management, and specialized services for our deafblind consumers. In the written testimony that we submitted, MCB submitted a chart, provided you with some representation of the occurrence of vision loss by county and by cause of vision loss. These data stem from a project funded by federal reallotment dollars that explored the delta between legal blindness, which is 20/200, approximately 10% of vision, and vision impairment. Age-related vision impairment exceeds any other etiology in every county in Massachusetts. Most irreversible low vision conditions in the state and across the country are caused by age-related eye diseases. That chart contains lots of other information, and you may want to review it and gain some additional knowledge about the different conditions that lead to legal blindness. So some of the areas that MCB will continue to attempt to make progress in 2024. First, we are continuing to try to serve new and existing consumers. Currently, more than 30,000 individuals are registered with MCB. The agency hosts 2 events to educate eye care providers annually. We attempt to teach them about the services that MCB offers and also make them aware of MGL C6, Section 136, which requires them to register someone who has been declared legally blind, in their opinion, or in their work at when they see the patient. We also will attempt to improve labor participation amongst working-age blind, with nearly two-thirds of working-age individuals with disabilities not in the labor force. Our community faces some long-standing challenges. MCB is currently planning our 2023 internship program. This program has been operating for 21 years. Consumers who go through this program develop some valuable information to put on their resume, gain some valuable experience meeting individuals and establishing a network to use later on in life as they move towards employment. And they also get a taste of different sort of industries that we place them in the state of Massachusetts. We have reviewed the individuals who have gone through our internship program and have found that about 80% of them are individuals who achieve employment and move on and using that great experience that they picked up as interns in MCB's program. Last year, MCB placed 63 consumers in various internships throughout the Commonwealth. MCB hosts a reverse job fair that brings 30 employers in Massachusetts together with job-ready consumers that are eagerly ready to work and are ready to start an interview. And in some cases, consumers have obtained jobs right from those interviews. So that's been a great program for us over the past several years. We'll continue to move forward with that as we move on. Also, another area that we hope to improve is the independence and self-determination for seniors. Approximately 500 seniors attend different support groups. We currently have 53, and the goal is to expand that number during this coming year so that more consumers can take benefit of attending these groups. It is found that individuals who attend these groups learn from other individuals attending the groups and also gain valuable support from each other as they are experiencing the same vision loss situation later in their life. Another area we hope to continue to work on is we seek an opportunity to revive the MCB's public use law relative to small business opportunities for vocational rehabilitation consumers. MCB would provide people who are blind or visually impaired with employment opportunities in a variety of areas, including web and document accessibility. We also are utilizing the results from our AT survey conducted last summer to help align some of the service needs that our consumers have. And that's proven to be very helpful in fine-tuning some of the needs that our consumers have. So in conclusion, MCB will continue providing important social, residential, and vocational programs while seeking opportunities for continued innovation. The proposed funding in the FY24 House 1 budget will allow MCB to continue important initiatives while sustaining our three core programs for the community we serve. On behalf of Governor Healy, Lieutenant Governor Driscoll, and Secretary Walsh, I thank you for the opportunity to testify today and welcome any questions that you may have.
Great. Thank you so much. Deputy Commissioner, down on the South Shore where I reside in Mount Muratori, reside, we have the Talking Information Center.
Yes.
Do you know if they are specifically named in the budget?
So that's the $1.1 million that we talked about, that I mentioned. Talking Information is part of that network. So that was an earmark that was removed last year, and they are looking forward to having funding again for this year, from what I can tell.
Well, that's wonderful news. Do we have any questions from the committee? Senator Goby.
Yep, thank you. Thank you, Deputy Commissioner. I appreciate it. And I appreciate the comments that you made relative to seniors. And I'm going to be a bit parochial right now. I have a organization that works out of Gardner called the Polis Center that I'm sure that you're familiar with, that has been working with your organization for several years. But I know that they have some concern relative, and it may be what you mentioned about some of the earmarks that are not there right now. But specifically, I'm looking at the community services program and that social rehab, and specifically for those shut-in seniors. My understanding that in the Gardner area, which would encompass where we're sitting right now as well, that there are about 600 homes on a wait list, seniors that want to be have services that the Polis Center is able to provide, helping them, doing some adaptive technology, teaching them how to use things on a cell phone or on their iPad and so forth. So I didn't know if you could speak to that and what may be in the future for groups like the Polis Center trying to provide services specifically for those shut-in seniors.
So the earmark I mentioned that in the 1,000 account, 4110 1,000 account, Polis Center did get some of the funding from that earmark for last year. And they did serve some consumers. Obviously, the funding has probably run out, but we are still trying to serve consumers with some of our staff. We are still trying to serve consumers. It is a large number of seniors to serve, and so the earmarks did take some of that pressure off some of our staff. But as we move forward, we'll continue to serve as many folks as we can with the resources that we have at this time.
And just as a follow-up, so I know that there'll be many of us trying to advocate for some more of that funding. Would you, and I don't know, that 600 number for a wait list just for this area, does that surprise you?
That 600 number is probably, I haven't reviewed those figures lately, but that 600 is probably individuals that are in fact are legally blind that live in the area. And so we haven't surveyed those 600, so we don't know if they all are waiting. But anyone who's legally blind could certainly use some training, some orientation when it comes to using assistive technology, be it an iPhone, be it a special video magnifier, any of the devices that might help them. But so I'm not aware that 600 are on a waiting list. We don't have a waiting list at MCB. Consumers come in, we serve them, and we provide some of the services that we can. There's a limit on how much our rehabilitation teachers can do as far as time goes. Some of the folks need more training than others, and that may require more time. But again, the number may be correct that there are roughly probably around that number of people registered in the state, but they're in this area. But there is not a waiting list as far as I know, and from our directors, that there's no waiting list. There are people that are waiting to see folks. I think it takes about 3 weeks at this point to see 3 to 4 weeks to see a rehabilitation teacher after they've had a case manager managing the case at the agency. So, but if any of those individuals would like to receive services, they could certainly call our office, and we'll see what we can do for them and provide what we can, what we're able to do.
Thank you. I appreciate that. Thank you.
Thank you. Any other questions? You don't have any text? No? I think we're all set, Deputy Commissioner.
All right.
Thank you so much for
Thank
being
you very
here
much.
today.
Now I want to invite Executive Director David Seltz of the Massachusetts Health Policy Commission to testify. Thanks for your patience. Appreciate it.
I have a presentation.
Thank you very much.
That's good. For a second, I thought that whole stack was your brief.
Which department?
Health Policy Commission.
Thank you very much.
Thank you.
Thanks, Anthony. I really appreciate it.
Well, good afternoon.
Afternoon.
Thank you, Chair Cronin, and through you to the esteemed members of the Senate. Thank you, Chair Lenatra, and through you to the members of the House of Representatives. It is just such an honor to be able to testify before this esteemed committee today. I first want to just say thank you to this committee for organizing this great event today, and through you to your staff, who I know have just been so instrumental in making this such a seamless day. Thank you to our court officers and to the members of Fitchburg for hosting this in this really, really beautiful hearing room today. I started my career in state government nearly 20 years ago as an analyst for the Ways and Means Committee. And so I feel like I know firsthand how important this job is, how important your role is in developing the annual budget. It is a statement of values and priorities about where we dedicate our resources as a Commonwealth. And I'm just honored to be able to present on behalf of the Health Policy Commission. My name is David Seltz. I'm the Executive Director at the HPC. I did prepare a presentation for you today, which I will walk through, and I know we're running late into the day and really appreciate your thoughtfulness throughout this day. And I guess one more thank you just to the other commissioners and directors who testified before me who do just incredible work on behalf of the Commonwealth, and just really just sitting here listening to this incredible work has just been a pleasure today. What I'd like to briefly do is just provide a little bit of background about the Health Policy Commission, how the state agency came to be established 10 years ago, share some of the work that we've been doing recently, and then finally close with our budget request for the fiscal 24 budget. Massachusetts is rightfully proud of being a national leader when it comes to expanding access to high-quality health care. This commitment was most, I think, well-known and demonstrated by the passage of what we call Chapter 58 of the Acts of 2006. This was landmark health reform law spearheaded by the legislature and the governor at that time to make as its goal that every Massachusetts resident should have access to health insurance and access to high-quality care. This was a huge leap forward for one state to take this massive challenge on, the challenge of the uninsured. This state in Massachusetts not only came together as a community and as stakeholders across the healthcare continuum to pass that law, but then to make that law a success. Massachusetts, to this day, still has the lowest rate of uninsured of any state in the country. And of course, that law went on to become the model for the Affordable Care Act that was passed in 2010, a law that has expanded access to health insurance for tens of millions of Americans. But this promise of access to affordable health insurance and affordable care is pivoted on one word there, affordable. And Massachusetts, we have an incredible healthcare system, the envy of many other states and across the world. It is also a very expensive healthcare system. And as policymakers a decade ago, we're seeing that the rising cost of healthcare was having difficult impacts on both state government in terms of how we balance our budget with high and rising healthcare costs that were growing at near double-digit rates. That meant for policymakers such as yourselves, you would have to reduce funding in other areas of government, reduce funding in local aid and education and transportation in order to be able to continue that promise of expansive healthcare. This same story about crowding out when healthcare costs grow rapidly is not just limited to government. It's limited to businesses and employers, and especially small businesses in Massachusetts, who were seeing that, whatever revenue growth they were experiencing as companies, they would be receiving at the same time a bid from their broker saying it's going to be a 10, 12, 14% increase on your premiums for your employees. And as an employer, that then results in some difficult choices. Do I continue to provide the same level of coverage? Do I actually pass more of my costs in terms of the premium onto my employees in the form of higher deductibles and copays? Do I buy down on my insurance? Do I not be able to provide wage growth to my employees because I want to balance health insurance? And then finally, of course, this crowding out effect applies for families and individuals and residents of the Commonwealth who were seeing and have seen whatever increases that they may experience in terms of their wage growth be subsumed by, at the same time, even more rapidly increases in their healthcare costs. This first slide that I'm showing you here on slide 3 demonstrates this with some data. And here we're just showing since the year 2000 to 2019 the growth in what employees have paid in terms of their premium contributions, a 243% increase. The cost of a total family premium, almost a 200% increase. What employers have contributed to healthcare, 180% increase. And at the same time, other markers of economic growth, such as wage growth or inflation, far, far below those trends. This is the crowding out effect that policymakers wrestled with in 2012. And at that time, passed another landmark piece of legislation to try and bend the healthcare cost curve. So this law was, it's called the Act Improving the Quality of Healthcare and Reducing Costs Through Increased Transparency, Efficiency, and Innovation. It was a significant piece of legislation that I remember was finally passed on the last day of session on July 31st of 2012. And as part of this really comprehensive piece of legislation, it had kind of central to its goal this idea of setting a sustainable growth target, that we do believe that healthcare and what we spend on the investment in healthcare should grow, as do other parts of our economy, but should it grow so much faster that we're forced to make those difficult trade-offs? And so this idea of sustainable growth, still growth, but just at a more moderated and affordable level, is embodied in a goal that we call the healthcare cost growth benchmark, which I'll speak a little bit about, but is basically a target for annual growth in healthcare spending in the Commonwealth. As part of the same legislation in setting this goal, it also established a brand new state agency in the Health Policy Commission. The Health Policy Commission, or HPC, is an independent state agency that was tasked to monitor and to measure the state's performance against the healthcare cost growth benchmark, and to work with other state agencies as well as all private parts of our healthcare system and community to work together to identify opportunities to create efficiencies to be able to meet that target that we had collectively set. There is another state agency, the Center for Health Information and Analysis, or CHIA, which was an existing agency but got a new name and a little bit of a new mission. But the Health Policy Commission was truly a new agency, and I was the first executive director of that agency 10 years ago. Importantly, the vision of this legislation is not cutting costs at the expense of everything that matters in healthcare. The vision is one of better health and better care at a lower cost, that we can achieve these triple aim goals together. And so we could find ways to cut costs in our healthcare system, and that could have very detrimental effects to access and to the care that people need. How do we balance these things together and identify solutions? Another important part of our vision that we have expanded on in recent years is the integration of health equity into this work. We are very cognizant of the fact of the interrelationship between healthcare access, healthcare outcomes, healthcare affordability, and health equity. We see that there are drivers of inequities and disparities of healthcare that stem from a lack of being able to access care when we need it. And so while our core mission has and will always be around advancing affordability, we think that advancing health equity is absolutely integral to that mission, that they are one and of the same. And so we wanted to change our mission statement to reflect that. And some of the words in orange here are changes we made to make that clear that this goal is one for an equitable healthcare system, and then the benefits would apply for all residents across the Commonwealth. Just briefly about our structure, because I think we're a pretty unique state agency, certainly different than many of the agencies you've heard from today. We are an independent state agency. So I report to a board of directors. This board of directors is appointed by the governor, the attorney general, and the state auditor. And you can see on this slide that each of those constitutional officers has a set of appointments to the board. And in law, there are actually certain categories that each board member must have in terms of their expertise and experience. So we have someone with an expertise in behavioral health care, someone who with expertise in healthcare consumer advocacy, a primary care physician, et cetera. I would also note that the Secretary of Health and Human Services and the Secretary of Administration and Finance also sit on the board and act as important liaisons for our collaborative work with the executive branch. I report to that full board, and importantly, as this board does represent important areas of expertise across our healthcare community, we recognize the need to bring others into this conversation as well. And so you can see that line to the right of my little face. That is the HPC's Advisory Council. This is a 35-member advisory council that I meet with quarterly to discuss the work of the agency and our vision. And this advisory council includes representatives from across the care continuum and beyond, including representatives from pharma and biotech, disability advocates, advocates in home care and in senior care. The list kind of goes on, but we felt it was really important to bring all of these different perspectives into the work of this agency. Just a minute on the healthcare cost growth benchmark. As I said, it is a goal. It is something, a measurable goal. It is not a cap. We, as a Commonwealth, have exceeded the healthcare cost growth benchmark in the past. But it provides a way of annually kind of looking at the data and understanding where are our healthcare trends going. Are there opportunities? And I think, to me, with the benchmark, it's not about whether we hit it or we don't hit it. What's more important is to understand why or why not, and to go deeper into the data, and that really provides that platform. It is not a cap on individual providers, what they can charge or what they get paid. It is not a cap on individual health plans and what they can charge. It is really kind of an all-in goal and target. Really, there is one accountability mechanism for the healthcare cost growth benchmark as currently written in law, which is that the Health Policy Commission can review individual healthcare providers and health plans and their spending. And if we find that they have excessive spending that exceeds the benchmark and for whom a performance improvement is warranted, we can require that provider or health plan to file with the HPC and to implement what's called a performance improvement plan. We would only and have only required a performance improvement plan after a very thorough, multifactorial review of that provider to really understand what is driving their healthcare costs and to make sure that we understand before requiring a performance improvement plan, are there things that are truly outside of that provider's control that are raising spending? And that would mitigate, of course, our concern. So there, it is not a bright line test. It really just provides a platform for conversations and discussions and potential accountability through the performance improvement plan process. I'll speak a little bit about that in a minute. Since the passage of this law 10 years ago, many other states have looked to Massachusetts to see if this is a model that could be replicated in their own market, this idea of setting a measurable goal that everyone can work towards together. And I'm pleased to report that as of today, there are now 8 states that have implemented, it's called different things in different states, but this idea of a collective goal, an all-in goal of looking at healthcare spending to be able to promote policy development that advances cost containment. Many of these other states, I should mention, have directly copied our statute and the bill that was passed here 10 years ago, and in many cases have gone beyond it, adding additional oversight and accountability. Today, in the United States, 1 in 5 Americans live in a state with such a target. So how do we do our work at the HPC? How, as an independent agency, are we working to try to bend that cost curve and to work with the healthcare community to meet those targets? Well, as I said, we don't cap prices, we don't regulate prices, so many of our powers and authorities are really around collaborative action. The first area that we work on is research and reporting. We've built an incredible data analytics team at the Health Policy Commission to be able to dive really deep into the data, use truly novel data sets and methodologies to understand the drivers of healthcare spending. We are a partner. We actually have invested more than $100 million into community hospitals and other community health organizations over the last 10 years, working with them, investing in them to implement and evaluate innovative new ways of delivering care that achieve those goals. We're a convener. We know that we live in a rich community of healthcare experts. How can we bring others to the table to discuss these issues and challenges and to find solutions? And then finally, we act as a watchdog. And here we act on behalf of the residents and employers that struggle every day with the cost of healthcare, and will identify activities or activities that certain healthcare systems or health plans are pursuing that are counter to our goals, and we will identify that publicly. So with each of these 4 levers, I just want to give you just a really brief sense of kind of going one level deeper, a high-level flyover of some of these functions. So first, let's start with some research and reporting and talk a little bit about what we have learned about healthcare spending over the last 10 years and really some of the more recent trends where we've had extreme disruptions with the pandemic. So here on slide 11, this is every dot here represents a year where we have the data for healthcare spending growth, and the dotted line and then kind of the solid red line indicates where we had set that target or goal. So you can see over the 8 years that we have, actually 9 years that we have, that there have been years where we have been below and there have been years where we have been above. I would note the extreme disruptions that you can see at the end of this chart due to the pandemic. And so the circle blue showing a negative 2.3% growth in healthcare spending from 2019 to 2020. This is really a reflection of the reduction in use of services as the pandemic necessitated the shutdown of certain in-person services. And some of those services have still not yet even returned to pre-pandemic levels. And then you can see the other not filled in circle there, which is the 9% growth, which represents the next year, where we went from kind of the nadir of the pandemic to the second year of the pandemic, where a lot of care did return to the healthcare system in person. And so you see a big increase. Notably, and I think most importantly, though, you see a big swing both ways there. But if you average those 2 years out, you actually get 3.2% annual growth. And over the course of this entire time span, average annual growth has been 3.52%, below our initial target of 3.6%. When we compare ourselves to, on that same metric to the country, here I am showing annual healthcare spending growth in the United States and in Massachusetts. The United States is in blue, Massachusetts is in orange. And you can see throughout the 2000s that Massachusetts often and sometimes far exceeded the growth rate of the United States. But really, throughout the 2010s, during the time period through which this law has been in effect, you can see that the orange line has been below the blue line in just about every year, including in the two extreme kind of pandemic years. This indicates to us that this effort has had at least some moderating impact on healthcare spending growth, although I will acknowledge we have a lot more work to do. When we look at just the last 2 years, it's always good to kind of dive beneath the numbers and try to understand, okay, well, where are those areas where we've seen some expanse in expenses? And so this is averaging kind of from 19 all the way through 2021, so kind of averaging out those swings. And notably, there was one category of service that grew in both years. Many categories of service, as you might imagine, had a negative year in 2020 and then a big rebounding year in 2021. One of the notable categories that did not experience a decrease in either year was pharmacy spending. So our pharmacy spending increased an average of 7.7% a year during these years. There are other areas where we have seen increased spending growth in the hospital outpatient, which is kind of common minor surgeries, tests, and labs. That was increasing at 5.4% a year, and other categories of service here. But I wanted to share this just to reflect that you want to go beneath the numbers to understand not all things are growing or increasing in spend at the same rates, and where you might identify those opportunities to moderate spending. You want to tackle where the spending growth has been the highest. We have made some recommendations about further accountability and oversight of the pharmaceutical sector as necessary to continue this work. Unfortunately, despite some of the, I think, notable and good progress that we have made in terms of moderating our spending growth, I do want to reflect that the cost of healthcare is still very high in Massachusetts. Here, I am just comparing the average cost of a compact car, shown in blue since the year 2000, to the average cost of a family premium in Massachusetts. The average cost of a family premium has now exceeded $20,000 a year, exceeded the cost of that compact car. I think in our most recent data, which I don't have on this graph, it actually is close to $25,000 a year for a family premium in Massachusetts. So that's buying a car, well, maybe now even kind of a luxury car, every year, year after year. And these impacts on affordability trickle down to our residents in important ways. So here on this graph, I wanted to show this is the average out-of-pocket spending for a 30-day supply of prescription drugs for several common chronic diseases. And just showing from year 2017 to 2021, not that long ago, we can see that there have been out-of-pocket increases of 60, 65, 70% for what the average Massachusetts resident is paying out of pocket for prescription drugs for a chronic disease. What this leads to, and these affordability challenges and why this effort is so important, is because it leads to deterioration of access to care. In 2001, 46 Massachusetts adults said that they did not get the care that they needed because of the cost of care. They foregone care. They are skipping dental care. They are not going to their doctors. They are cutting pills in half, skipping prescriptions, or sharing prescriptions with other family members. 46% of Massachusetts adults in a very high-income state reporting that they can't get the care that they need due to cost. And 3 in 4 Massachusetts residents worried about being able to afford health care in the future. And why it's always important to go even deeper into this data. When we go deeper, we see that there are important disparities and that there are certain populations that are even more disproportionately impacted by these affordability challenges. And so when we look at the survey results for Black and Hispanic residents in Massachusetts, we can see that those numbers increase to 75% and 68%, reporting having an affordability burden in the past 12 Moving on to our role as a watchdog. So here we have a number of tools to try to understand the changing healthcare market and to steer accountability so that we are increasing our affordability. I'll mention 4 things under this category. The first that we do is that we do monitor and evaluate changes in our healthcare market. And by that I mean kind of the business of healthcare. Which providers are owned by whom, which hospitals are part of what systems. We know from the academic literature that that actually has a huge impact on healthcare spending and costs, kind of the structure of our healthcare market and how consolidated or concentrated it may be. So when providers in particular are proposing acquisitions of new facilities or new joint ventures, they must file notice with the Health Policy Commission. That notice is public and transparent. And we can conduct an extensive review in certain circumstances to try to understand and to make public what we think the potential impacts of these market transactions may be on cost, quality, access, and equity. We have conducted a number of these reviews over the past 10 years. The most recent of the extensive reviews we did was a few years ago now, the merger of Beth Israel and Lahey Health System, our number 2 and number 3 biggest healthcare systems. We did issue a report raising concerns about the impacts of that merger. And importantly, as in part based on our report, the Attorney General and the Department of Public Health only let that merger go forward with a set of very specific conditions for approval that included conditions on price growth, conditions on investment in community health, other areas that we had identified. I mentioned earlier that we have the ability and authority to require a performance improvement plan if we identify a provider or health plan that is contributing to excessive healthcare spending. We have done this once in the 10 years. We do conduct an annual, very extensive confidential review. And last January, we did require that Mass General Brigham file and implement a performance improvement plan based on our review of their spending trends over many years. They did that, and after months of constructive dialogue with them, the Health Policy Commission Board did unanimously approve a plan last October that will save close to $200 million over the entire 18-month of the implementation time period. The numbers here are sometimes annual. We are in the process of constructively collaborating with MGB to evaluate their performance on this plan and to ensure that they implement it. But this is an important part of our accountability mechanisms. The third I'd like to mention briefly is that we do have a role with and a partnership with Mass Health when it comes to their review for their review of drug pricing and their ability to negotiate supplemental rebates for the Medicaid program. This was, again, authorized by important legislation by the legislature a few years ago that authorized Mass Health to be able to negotiate directly with a manufacturer on rebates. If those negotiations fail, Mass Health can refer a drug to the Health Policy Commission, and we would conduct our own independent review of the drug's pricing as it relates to its value. That part of this process has not yet occurred, so it has stayed at the stage of Mass Health being able to negotiate these agreements. And I don't have their specific numbers, but the last time I heard, those agreements had generated over $100 million, if not more, in savings to the Mass Health program. So we are proud to be a partner with them on this program, even if it hasn't gotten quite to the stage of referring a drug to us for review. And then finally, kind of a little bit of a left turn here, we operate within the HPC what's called the Office of Patient Protection. And here we interface directly with the public. This is an office within our office that helps consumers navigate an extremely complicated health insurance system. And we provide counseling and support to residents. We also administer a program where if a resident with certain health insurance is denied a service and the health insurance company says, we don't believe that that's medically necessary, we're not going to cover that. Consumers have the right to appeal. both at with the health insurance company, and if that fails, they can appeal with us, and we would conduct an external review with some of our contracted agencies, and we can overturn the health insurance company's decision and ensure that the residents have access and coverage for the care that they need. And I will tell you, of the number of waivers of appeals that we receive, about half are overturned in benefit of the consumer. So I wanted to pause here just to mention for all of you and your constituent offices, if you don't know about the Office of Patient Protection and you get constituent calls concerned about denial of medical services or medical coverage, we have a hotline. We have people reach out to me, reach out to our office. We want to be a resource to you and your constituents. Third, as I mentioned, we are a partner. So here we have been making grants into provider organizations over the years to really test innovative ways of delivering care. This slide, I skipped ahead to 25, but just shows the arc of some of the grant programs over the years. We have 3 that are currently operating on the right-hand side of the slide. And these 3, I think, are important to mention because the legislature had a role in each of these. The legislature actually directed us to develop a program with the Department of Public Health, which we call Mass Up, which is really about addressing the upstream determinants of health. We know that what drives good health is not always access to the healthcare system. It is about the environments and communities in which you live and reside. And so we have 4 programs right now that are working to improve food security and economic stability for residents in 4 different communities. And then the last one I'll just mention quickly is our Beside program, Birth Equity and Support through the inclusion of doula expertise. This program was seed funded by you, the legislature, in a $500,000 earmark a number of years ago. Thank you. We have taken that $500,000 and created an incredible program that is connecting Black birthing people to doula services. And doula services have an incredible and an emerging evidence base of really being able to reduce unnecessary complications, to improve the patient experience during childbirth, to decrease costs. And where we know that Black birthing people are often faced with disproportionately higher rates of complications during childbirth and during this episode of care, we really wanted to invest in support services that are directed, that doula services that both reflect the patients that they are serving and to be able to support the expansion of this. I would note that doula services, I do believe Mass Health is going to be covering doula services in the future. With this grant money, we were able to get 2 organizations really up and going and get their programs up and running. So we are working with this one, with the $500,000, we are working with Bay State Health and Boston Medical Center, so both ends of the Commonwealth. And just to reflect something really quickly, the Bay State Health program, they reached out to us about a few weeks ago and said that they had already kind of capped out how many patients that they could put into the program given the money that we had awarded them. And so that they were going to have to start denying patients that were interested in participating in the program because of the lack of additional award funding. Our team sat down, we looked at our budget, we found $50,000 of unallocated funding, and we moved it into that Bay State award so that they could continue enrolling patients into this important program. And then finally, the last strategy here is as a convener. And as I mentioned before, really, how do we bring people together to talk about the biggest challenges facing our healthcare system? And I want to highlight an event that we're going to be holding next week downtown Boston at Suffolk Law University, focused on the extreme challenges facing our healthcare workforce right now. The pandemic exposed and exacerbated many tensions within our healthcare workforce, from direct care workers to workers in our nursing homes and skilled nursing facilities, to nurses and physicians, workers within our hospitals. This has had an incredible disruptive effect and has resulted in higher costs across a number of different settings of care, and has ultimately impacted patient care, where we see that more and more residents are being stuck in emergency departments, especially residents presenting with mental health conditions, or are stuck in hospitals awaiting discharge to a step-down facility or to a nursing home or to home due to the lack of support in some of these areas. This is a big challenge, and it's one that I think is absolutely connected to our efforts around access and quality and affordability. And so we wanted to hold an event to bring together important stakeholders to discuss these challenges and identify solutions moving forward. As part of that event, we'll also be releasing a report that you, the legislature, asked us to do on examining the healthcare workforce and the impact of the COVID-19. So skipping ahead, a few minutes on what's next for us this year. We have a pretty ambitious agenda in terms of the different priorities that we are putting forward. In addition to all of the things that we're required to do as in our statute and mission, we're really trying to lean in this year on a couple of really big activities. One is continuing to bolster and to evolve our cost containment approach. We have 10 years of experience. We have identified opportunities for improving and advancing the way we think about moderating that cost curve. As I mentioned, healthcare workforce is incredibly important. Advancing health equity is part and parcel of every single one of these other things, and also important enough to mention on its own. As I mentioned, we see that there is opportunities to enhance the transparency and accountability of the pharmaceutical industry, and by that I don't mean just pharmaceutical manufacturers, I mean pharmacy benefit managers and wholesalers. There's an entire continuum of that sector that was left out, I would say, of the initial version of this law, where so much of the accountability and transparency was focused on healthcare providers and health plans. The main members of the pharmaceutical industry are not subject to some of the same accountability measures. We believe that this is a shared responsibility effort and that everyone should be underneath the tent working together. Reducing unnecessary administrative complexity. There's so much administrative burden that we put on our healthcare providers. If we can reduce some of that at a time of stress, let's pursue that. And then again, skipping ahead to our budget request for fiscal year 24. Importantly, and again, differently than many other state agencies, we are an assessed account. So what that means is that the number that is approved in the state budget by you for our annual appropriation, we then go and we assess both health insurance companies and acute care hospitals for the total amount of that appropriation. So it's a 50-50 split. Ambulatory surgery centers pay a very small amount there as well, sorry. And that money is then deposited into the general fund such that the appropriation and the state is basically held harmless. And so this has been an assessment that has been here for many years. It was modeled after the Center for Health Information Analysis, the other state agency that has had an assessment for even longer. And so our request for this year is shown on this slide at the last bullet, $11.4 million. This represents, I think, a very modest 2.9% increase from the available funding in the current year, and as I mentioned, will not impact the general fund or defer resources from other priorities. This is a maintenance budget. This is a conservative budget. I am mindful of the fact that this budget is assessed to hospitals and health insurance plans, and I think it's always been a priority of mine to keep our commission as efficient as possible. There are a lot of unknowns in healthcare, and so this is the best figure that we have at the moment. And I would note that there are a number of considerations and bills out there that would expand our healthcare reform authority. Those are not included here. So if there were additional responsibilities, we would welcome them, but may return to ensure that we have the resources to be able to do those to the level of quality that we've established. I think reflective here on this near final slide is just our staffing levels. We are a lean, mean commission. We have not really grown our footprint in terms of staff over the last 5 years. I think the requested amount will help us get maybe 2 to 3 more people, really. But we have been pretty efficient at kind of this level for a long time, and we'll continue to work hard to maintain that. With that, I would say this has been an honor and a privilege and just always a fun opportunity to be able to present before you. I believe that the work of the Commission is absolutely necessary to continue our journey of healthcare reform, and we look forward to working with you and to being a resource for the next 10 years. That is my picture, but that is not my contact information. My contact information is david.seltz@mass.gov, and you can reach out to me at any time as well. So with that, I will conclude my presentation. Thank you for the indulgence.
Thank you so much, David. Rep. Kilcoyne.
Hi, Dr. Sells. Good to see you, as always. I just wanted to comment and just thank you for the work that you and the Commission does. My district includes Clinton Hospital, which is part of the UMass Health Alliance system that also includes campuses in Leominster, from my colleague Rep. Higgins sitting next to me, as well as Marlborough. As I'm sure you're aware, that system primarily does serve many patients who are public payer or uninsured. And just wanted to thank you for the work that you guys do around accountability and ensuring that when we talk about healthcare costs and especially ways in which we can save costs, that we're not doing so that causes the disservice to those patients. Over the years, Clinton Hospital in particular saw a lot of cuts in services, and they're in a pretty good place now. But I think we all know that while that may be good for the bottom line, reducing services in areas, especially in areas like this where we have, rural areas surrounding highly densely populated ones, and we don't have a transit system similar to that of Boston. We don't have NETs. We have limited RTAs that serve this community. So having the ability to go 5 minutes down the road to get the care you need is so essential and critical. And as we see, growth of other hospital systems, that we need to know ways in which they're going to impact our local community hospitals as well. So, not really a question, but just wanted to just highlight that and just thank you for the work that you do that helps us serve our communities as well.
Thank you, and I will take the opportunity to just reflect. I think I am concerned about some of the trends with our community hospitals. Our first grant program that we ran was a community hospital-focused grant program, and we just saw this tremendous opportunity within the community hospitals of the Commonwealth that provide generally really great value, really good quality. They serve a higher proportion of public payer patients, as you mentioned. And yet are often, due to some of the broader market dynamics, the ones that receive the least amount in commercial revenue and in payments. And when we look across these years, there is a concerning trend of closure of services in rural communities and for providers that have higher public payer mix. We're losing maternity services in a lot of parts of the Commonwealth. We're losing pediatric inpatient services in a lot of parts of the Commonwealth. Those are also being consolidated. So, this is an area of interest of mine, and would love to follow up to really see if there is a way as a Commonwealth we can be a little bit more proactive in thinking about where do we need healthcare services, and rather than being reactive to then having to face difficult closure situations or entities rightly making business decisions to close services, could we have gotten ahead of that somehow? And so just an area of interest.
Yeah, no, and I thank you so much for those comments. I think, I speak for myself, obviously, but I know many of my colleagues in the area, we've all worked hard to make sure that we're maintaining that care and protecting our community hospitals, because they do serve such an important role, and looking forward to working with you and partnering you in the future to continue that work. So thank you so much. Thanks.
Representative?
Yeah, thank you so much. Good seeing you again.
Good to see you.
Thank you so much for all you do and your staff and all. At last week's hearing that we had, the combined committee of HPC and Healthcare Finance, I think it was Senator Friedman that brought it up with regard to this is all great information, but the general public that looks at this and says, my plan goes up, 10, 11, 12% every year. What is it that you think that we can do collectively as a body, or your group can actually do to maybe look at that and help figure that part out and see what we can do to kind of control that in the future. It's not going to happen overnight, I understand that, but.
Yeah, it's a really important point. Thank you, Representative, for bringing it back up again. And I'll say a little bit of what I said at that hearing. How do people feel healthcare costs? They feel it in their premiums, their copays, their deductibles, what they pay at the counter, right? That is how we feel healthcare costs. And some of the graphs and charts I show you where we're looking at, total healthcare expenditures across the state and, showing moderation. And that's really important. But it's not the same thing as kind of like how people feel healthcare costs. And so I think that there is an opportunity to expand and evolve our measurement approach here, to incorporate more measures that are really around kind of like, can people afford the care? Like how much of their income is going towards healthcare? I don't know what that right metric is, but just as we've made kind of the benchmark an important metric that we track year over year, maybe we need an affordability benchmark. And that way that we can keep and hold ourselves accountable as well to that. Other states are doing this. California, that recently passed a law that did set up a healthcare cost growth benchmark very similar to our model, basically has like a secondary benchmark too that's around kind of affordability metrics. And I think that is something that we could really learn from. Rhode Island goes even a step further. They have within their division of insurance standards for approval of health insurance plans that are based on can people actually afford these plans. There are ways within our regulatory structure and within the structure of the HPC where I think we can more firmly embed affordability as the ultimate goal that we're trying to achieve. We'll move forward on this. I think it's the right thing to do, and we'll start to model that out and come up with ideas to bring to you. We won't, I think the weight of law and legislation would be really helpful, but we'll move forward on it. As I mentioned, I do think that there are other important metrics that we could think of as well to track performance and track improvement. What if we had a health equity benchmark? I don't know exactly what that would be, but if we're trying to reduce and eliminate disparities in health and health outcomes, maybe we should set some pretty aggressive and ambitious goals and track our performance and see how we're doing. I think that we should be tracking how much money we're putting into primary care and behavioral health care. I think we should be investing more in primary care and behavioral health care. So I do think that there are absolutely ways to go beyond the current structure to pick up all of these other important pieces of healthcare spending and healthcare values. And I think we can learn from other states, but I also think we could be leaders on some of these as well.
Great, thank you.
Senator Miranda.
Thank you so much for your presentation. Quite type A. I was like, this is fabulous. I love paper. But something really important that you noted, and I want to talk about maternal health. I had a bunch of other questions, but I'm just going to focus on this. As a member of the House, although I'm not a mom, I'm a black woman. And I heard a presentation from the March of Dimes in my first week on the job that said that the 10 worst zip codes to give birth in Massachusetts, 6 of them were in the city of Boston and were predominantly black and brown communities. And I walked out of that meeting just with this extreme fear of like, I don't want to die. Even in a state that has the best health care, we're dying 2 to 3 times the rate of white women, and our babies are being born preterm or passing away 6 to 8 times that of white women. And so I was happy to work with then he's still the chair, Michael Witt's, around the $500,000 to the health policy. So I'm happy to see government spending actually working. And even though it's been 4 years, it's good to see that $500,000 initial investment, along with passing the Maternal Inequities Commission that we filed a report last year that basically chronicled what Massachusetts was actually facing, has been leading to better outcomes. The bad news is that Massachusetts is the most expensive state to give birth in. The New York Times just released a report that regardless of zip code, race, education, and economic status, black, wealthy women still had poorer outcomes than poor white women. We've seen closures of birth centers and maternity wards across the state. Most birthing people live in a maternity desert, even in the state that we have the best health care. And that's leading to even poorer outcomes, which we haven't improved the morbidity and mortality rate of black and brown women. And so my question is kind of technical on this. You know, you talked a lot about health equity, and I'm all for the benchmarks and for tracking them. But so often we can't improve outcomes because we're not even at the table discussing this. When we did the Maternal Inequities Commission, which was 95% people of color, some practitioners, some folks with the lived experience, either they had lost a partner during the postpartum stage or were taking care of children, birthing people who had passed away. And so I had a question about your advisory board and your board. Are there practitioners of color that are on those boards really driving the conversation? And if there isn't, are you willing, as the executive director, to really think about increasing the capacity of people of color to be able to sort of determine and fix? And the second question is around this maternity desert situation. We now have one birth center in the Commonwealth of Massachusetts, and it's in Northampton. I'm happy to say that there might be the neighborhood birth center that might be opening up in the city of Boston in the next year, God willing, which will address that. But we have no birth center east of Northampton, which is pretty much the western part of the state. And Brockton Hospital, I don't represent Brockton, but it is a gateway city, just like Fitchburg, with a huge population of people of color, and just said that they're at disaster mode. So they're not even able to serve birthing people in a state. It feels like we're in a crisis mode, even 4 years after giving $500,000, 2 years after doing the Maternal Inequities Commission. What are we to do? Because I don't want to see more women die. I don't want to see our children die, particularly in a state that has arguably the best public health infrastructure in the whole state. So I know that was loaded, but it's something I'm really passionate about.
Thank you. Thank you for your passion and for your leadership on this, and thank you for your advocacy to help us be able to put this grant opportunity in place. You know, I'll tick through a couple of things. I think first you asked about the makeup of the advisory council and the importance of incorporating voices into the design and implementation and evaluation of our work that is reflective of the communities we're trying to serve. The advisory council, I am proud that we have made very significant progress in diversifying that advisory council. That is something where I have the ability to make those appointments. And we have, I think in this last year, brought in a number of, I think we have there was a nurse, I wish I had her name. We have made strides to really expand and diversify that advisory council to bring those voices to the table as we implement those programs. For the HPC board itself, I do not have that control. Those are appointments made up by the governor, the auditor, and the attorney general. And I know that there are an interest in continuing to diversify that board, which we welcome as appointments cycle over. And I think the stats, just to reiterate, the stats that you laid out are pretty unconscionable for a state like Massachusetts, a very high income state, a state that prides itself on public health and our healthcare system. We have done some research and work. We had identified that birth centers provided really high value opportunity, really high quality opportunity for an alternative delivery of care. After the closure in Boston, we went and talked to the health plans and tried to understand, like, how are they reimbursing for these services? Because the birth centers were kind of saying, like, we can't make this sustainable. There's not a business model here. And talking to the health plans, it's okay, but if we funnel more of these women into the hospitals at 3, 4, 5 times the cost, why wouldn't you support these alternative settings of care where they have a track record of high quality? I don't know that we had a lot of, good information coming back to us about that. But I do think that if we're going to, and I do believe we should be expanding alternative settings of care like birth centers, we need to really think about how we're paying for it, what the business model is, to make sure that, again, we're not just putting more and more money into the most expensive settings of care. Let's find those opportunities. In terms of your broad question of like, what do we do? How do we solve this? I do not have the answer for you. You said earlier that we're never going to improve on things that we don't measure and track and understand. We do actually have a lot of outcomes data on this, and it's pretty devastating. And so I agree with you. This is a crisis, and I wish I had the right perfect answer for you. I would absolutely take another $500,000 earmark if you want to advocate for that. I'm not going to promise that this is going to solve this. This is, some of these are issues of systemic racism, candidly, in our healthcare system, and yet that we can't just accept that.
Yeah. And thank you. I'll schedule some time to talk about that and then send the recommendation to the HE or the auditor or the governor around the board makeup. But we can't keep throwing around the word health equity when there's a huge population of birthing people that are not getting the equitable services in the Commonwealth. And so that's where I'm trying to raise the issue for my colleagues, because it's an incredibly important thing. And I just want to leave with one more fact. During COVID-19, 42% of Massachusetts residents chose an alternative place to give birth because of fear. Hospitals were not safe. So they had birth in their homes, or they tried to find birth centers. And the 1 or 2 centers that were left, Beverly's now closed, were really overwhelmed. And it is unconscionable for us as a state that has this many resources to not be providing the quality of care that we need to. So thank you for your presentation.
Can I just add one final note on that? With the BESIDE program and the grant program that we're running, we really, as part of the evaluation of that program, to try to understand, was this successful? Were we able to achieve positive outcomes? We very purposefully put it as part of our evaluation, actually talking to the patients and asking them about their experiences with doula services and their experience through the program. And I will share this kind of shocking realization when we talk to a contractor who's, kind of advising us on the evaluation. They were like, well, that's not typical. We don't actually typically ask the people who receive the services what they thought of that. That's not really part of our grant evaluation process. And I found that to be pretty disappointing. And that's, I think, something that we have to do. So thank you.
Thank you, Director. Certainly appreciate your presentation and the work that you do. Was hoping that you might expand a little bit on specifically the drug pricing review process, and specifically in that where the intersection of a drug's price comes with its value. And for context, of course, when we hear of situations like the insulin price spike, where it's a relatively common drug that has an inexplicable large increase, that's problematic. But for further context, I come from a family with extensive history with hemophilia, a rare bleeding disorder, and my 2-year-old nephew's on Hemlibra, a drug that took decades to develop and costs somewhere in the range of $3,000–4,000 a dose, but it allows him to live a normal life. And in Massachusetts, we have the world's leading life sciences and biomanufacturing, putting hundreds of millions of dollars into research for rare disease treatments and therapies, where oftentimes there's maybe a couple hundred patients in the entire state or across the country to benefit from hundreds of millions of dollars of investment. So where is the intersection, and how do we balance ensuring that that research continues, that life-saving therapies are available? Obviously, there's an economic piece to that that's incredibly challenging. So just wondering if you had any, background on that.
Yeah, absolutely. And I think you've very articulately described the challenge here of wanting to maintain and support and expand our innovation in bio and medical technology. This is a centerpiece of our economy, but even more than that, it creates life-changing changes in people's life and care. As a side note, this is why I think it's always important to dive beneath the data and understand what's going on. In one of those years where we went through the benchmark, where as a state we had healthcare spending that was above the benchmark, it was because of the introduction of a new therapy. And that therapy was a cure for hepatitis C. It was introduced at the market at a high price, but it was a cure that indisputably resulted in a quality of life improvements, extended life for so many individuals. And so, when I look at that year and I say, oh, we were above the benchmark, I'm like, well, maybe that was a good thing, right? So I think that context is important to all of these things, and I think the balance is the word that I would probably stress. As we have thought about, we have not yet had to do one of those drug reviews. And, even if we were to do one, the end of the process is really a report to the public. It doesn't really go beyond, that or setting, pricing or setting caps on pricing. But I do think that there is nonetheless value in trying to bring science and data and information to bear to say, let's look at the clinical evidence about the improvements that these drugs or therapies can have. Let's think about the cost of care and whether as a society we can continue to afford those, and how do we balance those things. I don't think that there's one answer, because it will really depend on kind of the clinical profiles, the populations, the impact. This is complicated stuff, don't get me wrong. But nonetheless, there are unfortunately other circumstances where the pricing that is being set, maybe this is a manufacturer that didn't do all of that research and development and just bought a patent from another company and then immediately increased the price to bear on the market. So, for every really, I think, positive example that we should be upholding and supporting, there are unfortunately examples of increasing pricing or setting launch prices at higher rates than either residents or we can, that we should examine, and that we should bring some data to try to understand. And so for me, it comes back to transparency and balance.
Good, thank you.
Thank you. We're going to try to go back to Zoom and recognize Representative Doherty.
Thank you. Thank you very much once again. Nearing the end of a long day. Thank you, sir, for this presentation. I have learned such a great deal in the past hour or so that you have presented, that you're worth your weight in gold just in that respect. So thank you very much. I thought about not having to add my voice to the chorus of voices who are concerned about community hospitals, but I thought, why not? Because the community hospital in my district, the 3rd Bristol District, Morton Hospital in the city of Taunton, has been the mainstay of health care for most of the time that I have lived here in the community. We have been subsumed by a for-profit organization that has really sucked the wind out of every single doorway that covers medical care across the community. So as you pointed out, first it was pediatrics. There are no pediatricians in this region. The nearest pediatrician lives in Easton. And then it was maternity and all of the services and supports that go along with maternity care, maternal supports, also well-being and health and well-being for women generally in the community. We have to go elsewhere out of the community. And then the Norwood Hospital closed its NORCAP unit, moved here to Taunton, and it is, for those who may not know, a unit in the hospital, 32 beds, that takes care of opioid-addicted persons. And they discovered recently that it wasn't meeting the for-profit standard that they had put forward, and so they have closed that unit. It's moving somewhere else in their catchment area here in Region 5. So there are 32 beds that were renovated in the hospital at ruinous expense, I'm sure, that will partially become surgical beds, and I don't know what will happen to that. And then all of this is exacerbated, as I think perhaps it was Senator Miranda who pointed out, the fire in the Brockton Hospital has shifted that sand underneath us. So we rallied, we demonstrated, we wrote letters over the years, had legislation filed to prevent this from happening. And of course, it has happened because there are only certain restrictions that can be placed on for-profits that come into the Commonwealth. And so I guess my question is, what is your strategy, if you can, to continue to advocate for the restoration of community hospitals where that's appropriate? And is there anything that can be done to slow down these for-profit organizations that are subsuming our community services?
Thank you for that question, and thank you for your advocacy over the years for Morton Hospital, a great community hospital. To repeat something I think I said earlier, I do think we need to step back and take a bigger picture of our healthcare market and really try to understand where do we need services and who is providing those services and make a plan. There was this thing in Chapter 224 about health planning and really just trying to understand where do we maybe have too many services, where do we not have enough. I can tell you my concern is that if we leave this to the healthcare market to figure out, we will increasingly lose capacity in community hospitals and rural centers. Capacity will continually be consolidated into bigger systems, into downtown urban centers, and at a much higher cost. I think that there is a role for government with these stakeholders. Bring people together around the table. We need to have a plan and then be proactive about implementing that plan so we're not, again, only reacting when we get the notice that's like, well, we're going to have to close that unit. Once a hospital files a notice that says, I'm going to have to close this unit, it's so hard to unring that bell. What if there was an opportunity to work with that provider before that point to have triage or crisis or something where we can be more thoughtful before we lose the capacity altogether? So I do think we need to be more thoughtful about this plan and not just kind of letting the market itself figure this out. And then to your second point, I do think that we need to evolve our strategies about the entrance of private equity into our healthcare system. I'm not just, I'm not referring to Steward necessarily here, but there are other for-profit private equity firms that have been increasingly purchasing physicians and practices, purchasing nursing homes. I think these raise important questions that we should be tracking very closely to understand, are their interests actually aligned with providing great quality care and access, or are their interests really around a distressed asset that they would then flip for a short-term profit? And again, even, this isn't necessarily private equity, but we see the Amazon entering this market as well. So I think important for us to be to be evolving with a rapidly evolving healthcare market and examining all of these different dynamics. And I hope that we can stay at the forefront of that. But thank you, Representative.
Thank you. And that's a message of hope as my ears are receiving it. So thank you.
Any other questions from the committee? All right, seeing none. Director, thank you so much for your testimony today.
And again, consider me a resource. Thank you.
Thank you. I'd like to invite Executive Director Mary Trong from the Office of Refugees and Immigrants, and thank you for your patience.
Thank you so much for your patience. I cannot be as articulate as David, but I have 2 long pages of script to go through, so please be patient with me as well. Thank you. So good afternoon, Chair Lanatra Cronin and members of the Joint Committee on Ways and Means. My name is Mary Trong once again. I'm the Executive Director for the Office for Refugees and Immigrants, ORI. I would like to begin by extending the heartfelt thank you to each and every one, the chairs and the members, for giving me this honor to speak before you and to answer any question you may have regarding to ORI's fiscal 24 budget. I also like to express my gratitude to Governor Healy, Lieutenant Governor Driscoll, and for their proposal of $2,036,958 in state funding to invest in brand new administrative line item, which includes increased program capacity and oversight, and continued support for our Citizenship for the New American program, which is CNAP. Which will provide services to more than 1,700 refugees and immigrants. This appropriation will also support our financial literacy for newcomers, which is FLN program, to provide much needed financial training to 300 newcomers. So with your help, we can continue to make an impact on people's lives. I would like to highlight some of the important work that OI has taken on in the last few years, utilizing additional state funding appropriated via the supplemental budget, underscoring our need for this essential administrative expansion. So first is, after years of low number of refugee arrivals due to the federal policies, Massachusetts received a certainly influx of Afghan humanitarian parolees. Massachusetts received this AHP who arrived in Massachusetts as a part of the operational Ally Welcome and were assigned to the state's 6 resettlement agencies. In addition to implementing multiple newly federally funded programs for the AHPs, OI established the Afghan Emergency Assistance Program, known as AEAP, to distribute $12 million in state funds allocated to the Massachusetts refugee resettlement in the Chapter 102 of the Act of 2021, titled Act relative to immediate COVID-19 recovery needs. So under the AEAP, the resettlement agency have provided approximately 1,800 AHPs with direct financial and immigration assistance. And receive the infrastructure support necessary to hire bilingual and bicultural staff and provide services. So during the same period, Haitian immigrants fleeing the economic and political crisis in Haiti were arriving in Massachusetts in significant and rising numbers. The legislature provided an additional $8 million for the recently arrived Haitian immigrants, also included in Chapter 102 of the Act of 2021. OI established the Haitian Refugee Assistance Program, the HRAP, to distribute the $8 million designated funds to the Immigrant Family Services Institute, known as IFSI, consistent with the statute. So under the HRAP, IFSI provided approximately 1,600 eligible recently arrived Haitian immigrants with direct financial assistance and immigration assistance, and received funds for IFSI's administration, the program. So in July 2022, OI initiated a third major state-funded program referred to as the Mass Resettlement Support Program, the MRSP, to distribute $10 million in funds designated in the fiscal year 2022 supplemental budget for the Massachusetts Refugee Resettlement Agencies to provide support for immigrant and refugees, including including recently arriving Ukrainian humanitarian parolees. So similar in structure to AEAP and HRAP and MRSP, is projected to provide direct assistance and immigration services to approximately 2,000 eligible immigrants and refugees. So finally, OI has created 2 new state-funded programs to help address the surge in immigrants arriving in Massachusetts and in immediate needs of shelter and assistance. In coordination with Department of Housing and Community Development, the HCD, OI established the Housing Stabilization Program, the AHP. The HSP was funded by the Housing Preservation and Stabilization Fund, administered by the HCD. This is through the Mass General Law C-121B, Section 60. So through HSP, OI provided emergency housing assistance through community providers to meet the immediate housing needs of immigrant families eligible for the HCD's Emergency Assistance Program. Additionally, targeting this population, OI has issued a request for responses to provide case management and limited legal assistance to immigrants in and or qualifying for emergency assistance. So Governor's fiscal 24 budget supports a 1 million expansion for ORI to establish a new administrative line item to continue the work listed above and expand programmatic capacity. The $1 million will fund at least 6 new full-time employees to formalize state-funded administrative capacity to address the changing needs of immigrants across the Commonwealth. So these essential positions will allow ORI to be more proactive when thinking of how to address the needs of immigrants and refugees across the Commonwealth. So in closing, I would like to say that it has been an honor to work on behalf of the state to integrate newcomers into the Commonwealth. So thank you for the opportunity to present our fiscal year 24 budget request, and I'm happy to answer any questions.
Great, thank you so much. Does anyone have any questions on the committee? Yes.
Thank you so much. One of the questions I have, you spoke about IPSI, which is in my district, yes. And I was really proud to work with the Asian American Caucus and my colleague, Senator Collins, and Representative Randy Fluka-Oakley. Once we saw the budget that had $15 million for Afghani refugees and did not include Haitian migrants, we decided to write a letter, and the legislature supported us, and we were able to get that $8 million. I have the third largest Haitian American community and Haitian community in the whole country, only a third to Miami, Florida, and New York City. Communities like Mattapan and Hyde Park, Randolph, Brockton, and Everett make up like the top 5. I didn't see anywhere in your budget. I saw $13.5 million for Afghani refugees, $4.25 for Ukrainian refugees. What I'm wondering is, where's the Haitian migrant situation? That $8 million went by really fast, particularly with the cost of living and the support services needed for those migrants that are still arriving every day. Some of them are arriving in Boston, but some of them are arriving in bus stations across the state. Is that hidden somewhere in your request, or is that not just directly stipulated? Because I do believe we're missing the mark if we're not directly sort of creating the line item to continue to do the work. Folks, once they get their resources, those resources are gone in a month, 2 months, 3 months, and they might need to come back for other services. Or for the newly arriving migrants, we might need to reissue more resources to organizations like IPSI.
Thank you for asking that important question, because it's always about money. In order to increase in our capacity in general, you need to have funding to support more work and more support for that's so needed for these recent newcomers. So at the federal level, we addressed that question to our federal Office for Refugee Resettlement, in particular to help support the Haitian. And as you know, the Haitian refugee immigrant, they have been supported as OR eligible refugees. So they have been receiving the cash assistance that is, it used to be for 8 months. It has changed from the last 2 years to up to a year. So they get that cash assistance, and they get all of the support for case management, housing, search, helping the children enrolling in school. The OR eligible population include the Cuban Haitian. But in our Commonwealth, we have been welcoming more Haitians to our state than the Cuban. But these two populations have been OR eligible since going back for over 20, 30 years before I've been in this role. So they will continue to receive the support. That is on the federal side. So the only concern that I have about, in particular, the Haitian refugees, are that I think the issue has been not receiving the employment authorization document in time. So that's something where the United States Citizenship and Immigration Services have been working on to address that slowness in processing. They're eager to work, And meanwhile, they could not because of that situation. Meanwhile, they've been enrolling in large number from our service providers for employment preparation, learning English as much as they could. I'm talking about, in particular, the Jewish vocational services that they've been enrolling many of the Haitian newcomers to help with preparing for them when they're ready to work. But meanwhile, they're learning English. And from the state side, we continue to receive many calls from many people from all over the world, not just the Haitian in particular, or the Ukrainian. So they're looking for sponsors. The good news is that there's so many private community sponsors. There's a program called Community Circle. They have been working alongside with the resettlement agency to help refugee and immigrant individual and family to address any concern that they have, giving them information, and our office as well, connecting them to services in general, so that we want to be sure that we help address anyone and not letting them feel that they are isolated or they're not being heard. So it's wonderful to see through your support that IPSI received $8 million. They're very much appreciative of that. We work with Dr. Gabo. As you know, we're working now on another state earmark. And so, yes, Dr. Gabo is someone that we work closely with in addressing the need for the Haitian immigrant and refugees in general. So did I answer your question?
Yes, thank you.
Thank you so much for that important question.
Thank you. Representative Peace.
Thank you, Madam Chair. Yes, I have a question about like the community notification, because I think we've had some refugees that were brought in, like Ukrainian refugees, but they were kind of sponsored by some churches we have in our city and community. But I don't think, especially like the school or the city, is getting notified that we're getting this influx of people who don't have very, if at all, English skills that are going to be incorporated and put into the school system. So obviously there's going to be more services. So I'm just wondering how that notification period, and if that's going to be too long, then I don't mind you following up with me at another time. But I just want to make sure that that's kind of a really kind of tightened up between either transition assistance or reaching out to the education department or just the community at large.
Yes, thank you for that important question as well, Rep. Peace. So on a every 3 months, on a quarterly basis, we have the quarterly consultation with all of the local stakeholders, and we conduct this through 4 different regions, from Eastern Mass to Central Mass to Western Mass. And so we have this conversation to address the need and how we can resolve together issues of concern, from how many refugees will be arriving in our local town and how have they been able to serve. So among all of the diverse local stakeholders, we address those issues because the participants have always been very diverse from different services, from law enforcement area to school, to healthcare. Basically, we have this conversation quarterly. So I would love to give you a schedule of this conversation if you would like. We can send you so that you can send someone to come and address issues of your concern, because this is where we have this kind of conversation. How are we able collectively to help address the needs of these newcomers?
Yeah, I appreciate if you could follow up, send me some information on it, because again, the integration piece is the key. We just can't have them coming in and then they're just getting left there. I mean, I got a call from a constituent the other day with some folks who came in the fall, and they were having a little tough time about getting some maybe some fuel assistance to help them get through the winter and things. So now I'm going to reach out and see what's going on there with their community services. But anyway, thank you.
Thank you.
Any other questions? Again, thank you so much for your patience.
Thank you.
Thank you for being here today.
Sure. Yeah, absolutely. And to conclude, I want to thank our very gracious host, the City of Fitchburg, Mayor Dina Talley, my colleagues in the Senate for joining today, Senators Goby, Miranda, Senator Comerford online. Hearing the testimony from the secretaries, commissioners, directors is truly indispensable to this committee's work to put together a budget that meets the needs of our state and reflects our values. So we're grateful beyond measure for all the testimony that was provided today, and beyond that, all the work you do throughout the year and every day to serve our state. And I will just conclude by thanking my staff, who is the best team in Massachusetts politics, for making this a seamless hearing on the road today. So thank you to Team Cronin.
Thank you. And I'd like to reach out to all my House colleagues and thank you for your important work that you do. And again, our staff as well. And your staff. Thank you.
Thank you.
Sam,
Motion to adjourn.
So moved.
Oh.